type 1 and thoracolumbar and lumbar scoliosis type 5. Type 1 and type 5 scoliosis can be corrected both anteriorly or posteriorly. It depends on your choice and your experience. You can choose whichever approach you want. But the other types, double thoracic, triple measure, double measure, and thoracolumbar, lumbar measures, deformities must be corrected posterior. The posterior spinal fusion from the neutral vertebra above to the stable vertebra below. That means if central sacral vertical line is bisecting lowest vertebra, this is the stable vertebra. This can be the lowest vertebra. In some thoracic deformities and some double measure deformities, there is a great controversy about adding the lumbar area to the fusion. If the clinically prominent lumbar curve is present, we will fuse the lumbar curve. And curves more than 50 degrees needs fusion. And shift of apical vertebra, lumbar apical vertebra, from midline more than 3 centimeters needs inclusion to the fusion. And if there is thoracolumbar kyphosis, we must go down to lumbar area. And if the correction at the bending or traction X-rays, correction ratio of thoracal and lumbar is less than 1.2, we must add the lumbar area to the fusion. Here an example of selective fusion. You see Lanka type 1, and there is also a lumbar curve. But during bending X-rays, the lumbar curve corrects itself, and this is the traction under anesthesia. So we decided in this case to make selective fusion. But later, some lumbar curves increased a little bit more, but without any imbalance and without any cosmetic problem. This is the example of selective fusion. How about shoulder imbalance? We take the X-rays in standing position, and when we evaluate the X-rays, turn the X-rays vice versa. We think that we make the plans that we are looking behind the patient. So please keep in mind, if the right shoulder is elevated, proximal fusion to T4 or T5 is sufficient. If the shoulders are level, if you make thoracic correction, right shoulder will drop down. So to prevent this, we must go one level above. If the left shoulder is elevated, the fusion must go to T2 level. Here is an example, and this is the result. Anterior instrumentation is in the Lanka type 1 cases can be treated by anteriorly. Anteriorly, you can do it open, mini-open thoracotomy, or with endoscopic system, whichever you want. Cope-to-cope instrumentation is enough for these cases, and you can get very good thoracic kyphosis. Here is another case, Lanka type 1, treated with anterior. And to prevent junctional kyphosis, below and above levels can be added with cages to prevent kyphosis. In Lenke type 5 cases also can be treated with anteriorly. Very good lumbar lordosis can be achieved. And sometimes we can use double rod to make a good correction. Posterior instrumentation. Here is a case. We are looking behind. Lenke type 1. Bending X-rays. Thoracic is the main curve. Lumbar is flexible. And traction under general anesthesia. Lumbar curve corrected itself. And Lenke type 1, neutral, that means the neutral kyphosis. A, the central sacral vertical line passing medial to the pedicule, and right shoulder elevated. In this case, the surgical plan is to start with T4 and end at L1. Here is the postoperative appearance. Another case, 14 years old female, right thoracic, left lumbar curve. Lumbar curve is correcting itself very well. Traction under general anesthesia. You see the shoulders are level. Shoulders are level and central sacral vertical line goes medial to pedicule. This is A. So our plan in this case is T3 to L2. And this is the clinical result. Oh, sorry. This is another case, triple measure. And traction under general anesthesia. Lenke type 4. So this is triple measure case. We are planning to start at T2 to L4. And this is the result. Another case, this is thoracolumbar and thoracic, Lenke type 5 case. You see the thoracic lumbar curve is structural, also thoracic curve is structural. Traction X-ray, and in this case, right shoulder is elevated, so our plan is T4 to L4. This is the radiologic and clinical appearance. Here, another case, right thoracic scoliosis, but in MRI, we have seen that there is syringomyelia in cervical area. In these cases, the correction of scoliosis is very dangerous. So, first, we had done suboccipital decompression. After 6 months later, you see the syringomyelia is diminished, and surgery we have corrected without any neurologic problem in this case. Another case, this is the left thoracic scoliosis and kyphosis. This is atypic. This is not idiopathic scoliosis. So we must be very careful, and we must check whole spinal channel for any abnormality. Although we have done whole spinal MRI, we couldn't find any abnormality in spinal cord. So we done posterior correction with very good sagittal and coronal correction. In summary, aims of our scoliosis surgery are to get balanced spine, cosmetically appearance, acceptable appearance, and minimal fusion length. Okay, it doesn't work. Okay. Okay, general principles, major curve and structural minor curves should be fused. Single thoracic and thoracolumbar curves can be treated anteriorly or posteriorly. All other types must be treated posteriorly. Posterior spinal fusion from the neutral vertebra above down to stable vertebra. And if the lumbar curve is more than 50 degrees and very rigid and clinically prominent, we must add the lumbar spine to the fusion. And for the shoulder imbalance, if the right shoulder is elevated, you can stop at L4, this is T4, T5. Otherwise, you should go up 1 or 2 levels above. Thank you very much.
Thank you, Professor Mahir. Second comment also by Professor Mahir on groin load techniques for the immature spine.
Okay. Can you help me?
After the closure of the spine section, we will cover
The second is here. I don't know. No. Yeah. Yes, yes. Okay. Okay. Yes. Okay, thank you. My second topic is about surgical strategies in growing spine. There are two outcome-based forms of scoliosis. One is the standard scoliosis. These are the late scoliosis, late onset scoliosis, and thorax is flexible and vital capacity is normal. Lung development is normal, and there will be no any respiratory problems in these cases. These are late onset scoliosis. Adolescent idiopathic scoliosis is in this group, and other adult scoliosis. But there is early onset scoliosis. These early onset scoliosis have distorted thorax and volume depletion deformity and lung growth issues. Secondary to lung growth issues, there will be some respiratory problems. And if you make fusion in these cases, the spine will be shorter, and the patient height will be short, and vital capacity will be diminished. So these are the special cases for length sparing and the vital capacity prevention. These scoliosis are under 10 years old, and they can be idiopathic or sometimes congenital, neuromuscular, syndromic scoliosis, and some thoracic insufficiency syndrome. These are progressive and they may cause respiratory problems, neurologic problems, and early fusion will cause short stature. The most important thing is the lung development. The lung development mainly occurs the age of 5. And at age of 10, almost 50% of lung development has finished. So we must postpone the surgery after 10 years. But how do we postpone it if the curve is progressive? So this is the problem. So maximal spine growth is at the period of 5 years, and maximum increase of number of alveoli is before the 8 years. The aim is to control and correct the deformity before serious thorax and lung problems without interfering the spinal growth. You may delay the surgery by using casting and bracing, but it will take long time, 3 years, 4 years, and these are not very comfortable for the patient. And sometimes the thorax will become elongated due to long usage of braces. So we can do early surgery in these cases. We can make limited surgery, such as hemivertebral resection, and we can use growing rods, sometimes thoracic expandable prosthetic device. And the treatment classification is like this. First, the distraction-based growing rods are distraction-based. Second, the controlled growing. These are Luca-Trell, trolleys, or Sheila techniques. And tension-based. These are staple and tethers. Hemivertebrectomy, especially at the lumbosacral area, the lumbar curves, is very sufficient technique, and you may do it as early as possible to prevent the instability, imbalance. So this case is 1.5 years old, and after hemivertebrectomy at 5 years and at 11 years. So a very good result can be achieved with very small exposure and hemivertebrectomy. Growing rods can be used as Harrington rods, subcutaneous rods, Luca-Trell trolley, that means sublaminar wires with rods, single or double can be used. And vertical expandable prosthetic titanium ribs can be used for thoracic insufficiency cases. Growing rod instrumentation is done at the proximal and distal foundation. You can use hooks or screws, sometimes sublaminar wires in combination with these techniques to prevent pull out of the screws and hooks, because these are non-fusion techniques, and the implant failure at the proximal and distal areas are very frequent. You can use dominoes to connect proximal and distal rods, and you do distraction every 6 months under general anesthesia, or nowadays we are using motorized magnetic systems to make elongation. Here is an example of open growing rod. You see the dominoes, connecting dominoes, and every 6 months we distract it, and then we have graduated the patient. That means after age of 13, you remove all the implants and make permanent implants. Another case, this is a congenital one with dominoes and cerebral distraction. In neurofibromatosis also you can use this technique. First and last elongations you can see. And in meningomyelocele cases, they can be used. The main disadvantage is there is a need for repeated anesthesia every 6 months. You use sometimes single rods. Serial lengthening, it requires serial lengthening, and correction will be around 50%, and you can get 1 to 2 centimeters annual spine growth. There are many complications: pull-out, implant failure, rod breakage. We are now using magnetic implants. So you put these implants, and outside of the body you use special device for magnets, and every 6 weeks or every 8 weeks the patients come back and you make distraction 5 to 10 millimeter. And we use this magnetic field generator. This is minimal invasive implant, and you may do only proximal and distal incisions and put the rod subcutaneously. You can make correction, distraction, and compression in every case, depending on the situation. Here is the one case, 9 years old, and elongated, and after graduation. Another case, 4 years old, using these magnetic rods. These are very comfortable for the patient. Another case. Here is other girl. This is our first case of magnetic rod. And we have graduated her with very good result. Another case. First we have done classical growing rod, then we converted it to magnetic rod. Our series consists of around 50 cases right now. These were the old series, and there are many complications because these are non-fusion. Patients and families must be warned about serial surgeries. Unplanned surgery, 7 cases, and infection, proximal junctional kyphosis, pull-out are the main complications. Here is the implant failure. Treatment of early onset scoliosis remains controversial. Scoliosis is indirectly controlled or partially. Webster treats volume depletion deformity of thorax, expect complications, and warn the patients and families. Repetitive surgery, non-fusion means persistent force on the implant. So complication rates is acceptable in view of benefits. Growing rod technique should be used in patients where the primary problem is at the vertebral column. If the primary problem involves the thoracic case, Webster should be an appropriate option. Thank you very much.
Thank you, Professor Nair, for a very informative talk. If anyone has a question, take it out.
I'm coming near to you to get you very clear.
Oh, no. Okay, okay. So this is great work, but I'm asking very simple things because. So what would be your strategy? Because very simple things, non-operative. Infantile idiopathic scoliosis. So usually some of these cases are resolved. This is quite often, I don't know why might be. So there's certain problem. What about strategy fasting cycle?
एक गोल कर रहे हैं
We do several tests. Several tests. And we do 3 or 4 months. Sometimes then give
प्रेम से पढ़ो
and give the patient 6 months or 7 months, and we really try to catch time. But when the patient comes around 3 or 4 years, we change to emergency house.
But how long you keep the task? How frequently you change the task?
मुझे पॉइंटर दे देना
More than 120, something like that.
We have device in the nature of device for it. That nature of device basically is easy to build so that we keep on extracting more than 120 scoliosis, bring it to the over 70, 60, and then we put the operation.
On the general
it's basically
sometimes put hello, and put the operating table tilt and with the weight of the body on the general anesthesia causes very good traction. So this is
just to add to Dr. Gulson's just to add to your point, the device that we have modified is the halo pelvic traction. You know the halo jacket. We have modified it so that we put Shan screws in the pelvis and we distract it slowly, and the patient is not bed bound, the back is free, patient can lie down, move around, and we can show you the pictures where patients are walking and playing with their mobiles. Yes, so we distract it for 6 weeks, achieve a good correctable angle, and then we do instrumentation.
good option.
I think as
many times, but because of the patient problems, I have a problem.
I have a case I can show you later on.
Thank you. Now we are moving on the next talk by the Dr. Muhammad Fahim on the idiopathic scoliosis principle of management.
Assalamu alaikum ji. I hope the people aren't very sleepy after just before lunch, so I'll be making my presentation really quickly. and discuss the main features of the principles of management and how every orthopedic and a pediatric orthopedic surgeon especially should know how to deal with the scoliosis cases before referring them to a proper center. So my name is Dr. Muhammad Umar Fahim. I am working as a consultant in Gurki Trust Teaching Hospital under the supervision of Professor Atiq Zaman, and I have a special interest in pediatric scoliosis and pediatric spine. So Gurki Trust Teaching Hospital is a tertiary level teaching hospital, and we treat about 200 plus cases of scoliosis per year, and the majority of these patients involves the pediatric, the adolescent, and the young adult patients. So these are the primary patients of the scoliosis, and if the earlier that you get to deal with them, the better the results are in the future, because these patients, when the spinal curves progress so much, they cause cardiopulmonary compromise, leading to mortality of the patient as well. So early identification, early treatment is actually life-saving in these patients. So this is my team with all my mentors. So just a brief history about scoliosis. I can tell you that scoliosis as a problem was identified about 5,000 years ago. And there are texts with ancient Hindus, they using different kind of traction methods, putting feet on the patients, trying to correct these curves. And the father of medicine, Hippocrates, by 400 BC, he also has identified this problem, and he also used traction. So traction is basically a method that is still in use in dealing with scoliosis today. So this problem was identified very early, but the solution came very late, about thousands of years late. So by 1700s, the bracing techniques were initially identified that the scoliosis might be amenable to some kind of bracings. And these are the very earlier designs for the different kind of braces that were available at that time. So before starting anything, we'll have to define what is scoliosis. So scoliosis, normally we see a corneal deformity in the AP view, but in fact it is a three-dimensional deformity. Pointer काम नहीं कर रहा, मुझे change करना. So it is basically a three-dimensional deformity. The corneal plane, which we can all see and appreciate, if it is more than 10 degrees, we identify it as scoliosis. So a normal spine is 0 degrees, straight, plumb line. And the next deformity is the sagittal. If you see from the sideways, so if there is some deformity, 20 to 50 degrees the normal kyphotic level. If there is less or more, it also accompanies the scoliosis. And the third is the rotation. Because in all of these patients, all of you might have seen there's a rib hump. And that rib hump is basically due to the axial rotation of the spine, which causes the rotation of the ribs and produces the deformity that is so cosmetically visible. So it is a prevalence it has of about 2 to 3% in the adolescent population. And majority of these patients are female. So scoliosis can be further classified into structural and non-structural curves. So non-structural curves are those which correct when the patient bends, and these are not very primary curves. And the structural curves are those which do not correct, even on bending and traction, fulcrum, and any view. So most of the pediatric orthopedic surgeons would be dealing with different kind of patients, all of the neuromuscular disorders, from neuropathic to myopathic to congenital with the bony bars, failure of formation, failure of segmentation, to CP, polio, muscular dystrophy, Marfan syndromes. All of these conditions end up in scoliosis. But these curves are very structural and very easily identifiable. They have a large C-shaped pattern. From the superior spine to the inferior spine, it comes as a large C. So all of these curves are neuromuscular. I won't be talking about these or the degenerative ones. My primary talk for today will be the idiopathic. And in idiopathic, we always have infantile, juvenile, and adolescent. As I previously mentioned, these are the main populations for these curves. I'll be discussing a case of mine from the adolescent population. So a patient presented to me with a 15-year-old male. The deformity was identified 7 years back, and normally it's the parents that identify these deformities, and they roam around and they seek treatment, and sometimes they do bracing and other things as well. But he did not seek any definitive treatment for his scoliosis. The deformity was progressive. The mother said that the patient, the deformity is increasing through the years. It was not associated with any pain, fever, weakness, any shortness of breath. He had normal delivery, normal milestones, and belonged to a normal or average socioeconomic status. So when you see the patient, if you see very clearly, pointer मिल जाएगा? Excuse me, pointer. So if you see the patient, the shoulder has a little bit of disbalance, as Professor Gulson was saying as well. So if you see, the right shoulder is up. So initial clinical examination is the most important in these patients. You have to clinically identify the problems, because in order to correct any deformity, you have to first identify deformity, and then you have to use the countermeasures for these deformities. Whichever deformity you see, you have to apply the equal and opposite measures in order to correct it. So we have right shoulder up. The good thing about this patient is that the pelvis is normal. Pelvis is the base of the body, and the spine supports all the axial skeleton. So this deformity, due to these pressures, is increasing. If you see, this is the rib hump that I was talking about, Adam's form of bending, but that's not my topic for today. And if you see, just looking at this, and the spine or the neck is a little bit backward. So just by looking at him, I can see that the patient is compensating by backward shifting of his curves. So all these deformities I can see just by clinical examination, and I know I have a basic idea of what I need to do in order to correct this curve. So when I examine the patient, these are the, I've already discussed these. There was no normal hair, no skin patch or pigmentation for the cafe au lait spots or the myelomeningocele, no LLD, because the pelvis was neutral. If the pelvis is not neutral, you will always get an LLD, because it is not a true LLD, or it is a compensatory LLD rather. And all the neurology was okay, and there's no problem with any examination. So we proceed to the investigations, and this is where all the people in the crowd will come in handy as well, and I'll be asking questions from you as well. So we do x-rays in these patients, but these are specialized x-rays, and we term them as a scoliosis series. We sometimes perform a CT scan just to identify in the 3D CT scan the anatomy of the curve and assess the pedicles, because we want to instrument and put screws in the pedicles. So we want to know the size, the shape, and dynamics of it. Internationally, the navigation systems are there now, and we have it on our bucket list to get navigation systems for us as well. So it will make the instrumentation quite easy. In each scoliosis patient, always get the pulmonary function test, because due to the curve, it always causes cardiopulmonary compromise. The greater the curve, the greater the cardiopulmonary compromise. Before operating, we usually do the PFTs, also the echocardiography, to assess for any discrepancies. So we should know pre-op and post-op how to deal with the patient. A clotting profile is very necessary because it's a major surgery, and there's sometimes a lot of bleeding, and we need to optimize that as well, and the routine baseline investigations. So what is a scoliosis series? Scoliosis series is an assortment of about 5 to 6 x-rays. We get an AP, standing view, a lateral standing view, and sometimes we get these in the stitching form, so get the whole anatomy, just like a scanogram of the lower limbs, a scanogram of the spine, with showing the complete spine as well as the pelvis. We get a right bending, we get a left bending, we get a fulcrum view. In a fulcrum view, this is the main curve. So the most convex side of the main curve, you put a fulcrum or something in underneath it and allow the patient to bend over it, and non-structural curves that I mentioned before. So if you see in these bending x-rays, this thoracic curve, in here, it is not correcting. No matter how much bending there is on one side or on the other. This means this is a structural curve, and this is something that I have to deal with. In comparison to a non-structural curve, if you see this is a thoracolumbar curve. Here it is there, but on one bending x-rays, it is correcting. So it means that this is a non-structural curve. If I just correct the structural curve, the non-structural will follow by its own, and I have to just give it a stable construct, and I need to include these levels in my instrumentation as well. Dr. Gulson described the instrumentation level, so I won't be going into detail of that. The important thing for all of you to understand is the Cobb angle. This forms the basis of the scoliosis. If you don't understand this Cobb angle, you can never treat a scoliosis patient. So what is a Cobb angle? We see the higher the end plate of the superior most vertebra, which is most tilted before the start of the other curve. If you see, this is one curve, and then the next curve is starting. So the upper end vertebrae of this end plate of this vertebrae, and similarly the lower end plate of this vertebrae before the next curve starts. So 90 degree perpendicular to these, and the angle in between is the Cobb angle. This angle identifies how you will treat a scoliosis patient. If you can't understand that, you could never understand how to treat a scoliosis patient. So we did the standing radiograph for this patient. If you see the markers in the red eye, the primary thoracic curve, the blue ones is the main thoracic curve, and the yellow one is the thoracolumbar curve. So we have three curves, and when we calculate the curve angle, the primary thoracic was 35 degree, the main thoracic was 88 degree, as you can see, and the thoracolumbar was 64 degree. Another thing that we have to look at is the Rhesus score. We normally use this score, and this, if you see in the pelvic X-ray, you can see the maturity of this patient. There are different methods, Tonnes method, there are Saunders method. You can see the maturity, and the maturity tells us when to fix and when not to fix. Like Professor Gulson said, the early onset scoliosis, we don't have to fix this patient. Okay, I'll just continue quickly. So the correction in the bending was 60 degree, it corrected. In the left bending, it also corrected. And if you see, the sagittal balance was negative, so as we looked in the pictures as well. So in retraction views, it also shows correction. It means that this is flexible. So it can correct. It has the potential. Another important thing is when to do an MRI. Normally, we won't do an MRI unless it is a left curve, early onset scoliosis, rapidly progressive, foot deformities, on a left-sided curve as well, because there's always spinal tumors and any other pathology in the spine as well. PFT is normal. CT scan, we just need to look at these. All these are normal. So we described it as a Lenke 4 curve with all the structural curves, the primary thoracic, subthoracic, and the thoracolumbar, all were is a triple major curve. So what are the treatment options? Just, I'll take you 2 minutes if you can bear with me. So what will you do with this patient? I want to ask the audience. Would you do observation? Anybody for observation? Anybody for bracing and castings? Who is for the surgery? Okay, so 2 people are surgery and the rest of them are thinking. So good. So the bracing indication is 25 to 40 degrees. If you ever get a curve angle of less than 25, you just observe. No need to do anything and observe in regular follow-up. If you see it between 25 to 40 degrees, in the growing potential is still remaining, you will brace the patient. This is a Boston brace from the Boston Hospital. This is a Milwaukee brace. If the apex of this curve is below T6, then the Boston brace is used. If it's above T6, then the Milwaukee brace is used. These are important. The 16 to 20 hours a day it should be applied. Important thing is when not to brace. This is the important thing for all of you, that the curve angle projection, if even 5-6 degrees curve angle projection is seen in the brace, you should stop bracing because it will lead to failure. The absolute curve angle at any time, if it gets greater than 45-50 degrees, it will lead to failure. If we apply the brace, because the brace is pushing the curve into correction as well, and we achieve a less than 50% of the baseline. For example, it was 40 and we achieve less than 20, or more than 20 rather. So this is an indicator that will lead to failure, no indicator for stopping. And daily wear for less than 12 to 13 hours a day, and a skeletal endpoint, which is the endpoint of this bracing. When the patient reaches maturity, we can stop this brace if the curve is below 45 degrees. Then it will not progress. If it is above 45 or 50 degrees for the thoracolumbar curves, it will progress by 1 to 2 degrees per year and lead to cardiopulmonary compromise and eventually mortality. So our plan, again, was to do spinal fixation from T2 to L4 because of all the major curves. There was no significant blood loss. We use tranexamic acid and dihydroadenine sponges. And every surgery is done under neuromonitoring. 1 day ICU and 5 post-operative day we discharge the patient. This is surgery, and we achieve a corrective in the sagittal as well as the coronal planes. The patient is relatively happy. Shoulders are balanced now. Pelvis is balanced. And if you see, the sagittal balance is there as well. So it's a good correction. And the primary thoracic was 13 degree from 35, main thoracic was 17 degree from 88. We did multiple osteotomies in this. And thoracolumbar was also in the normal range. So these are the main parameters: balanced shoulders, balanced pelvis, and intact neurology, and no LLD. So thank you for your discussion. And I'll be happy to have any questions.
Anyone have a question?
Okay, so exactly. So a very good question for the audience as well. So a structural curve, as I told you, is that which doesn't correct, but a non-structural corrects. And the threshold for that correction is 25 degrees. If you get a correction, because the structural curve, if they are flexible, they also correct. But if they correct below 25 degrees, then it's a non-structural. And I don't need to look. But if it's above 25, then it's a structural curve. Yes, most of the times. And the 25-degree threshold is the limit.
Okay, now we are moving on to our tumor session. For the next talk, I would like to invite Professor Saito for his talk on the pediatric tumor reconstruction options. He has two talks, consecutive talks.
उसके बाद जो दो क्लास होंगी प्रोफेसर अशोक जोरी 2 and प्रोफेसर यसीन चीमा 2:30 after brothers जो दोनों क्लास
Thank you very much for giving me the opportunity. Again, is another different topic. Might be something different from this simple pediatric orthopedics as well. But everybody is dealing with some benign, some malignant bone tumors, and every pediatric orthopedic surgeon definitely see all kinds of patients in their clinics. So I will present. So I will go through the basics and show you the cases only. Not go through the theory phase, just give you the idea how many options of treating this benign and malignant bone tumors and what are the methods of reconstruction. And I will show our experience of using all the methods as well. So there are too many options. If you see in the benign and aggressive and malignant bone tumors, so reconstruction option is first one. We always prefer to look out the lesion in benign lesions, where to observe, where not to observe, where to do prophylactic fixation, where to do steroid injection, bone marrow injections, bone marrow substitute, sclerotherapy, and where we'll do the biological reconstruction, extended curettage, only decannulation for cysts and ABCs, marginal resection, autograft, allograft. So too many options for benign, but very limited options for aggressive and malignant bone tumors as well. Either we do the autograft, allograft composite, recycled bone, recycled composite orthodesis, flail, shoulder, hip, rotation plasty, and straight plasty as well. So I will show you the examples one by one. So Gill states, if you know the basic principles, you can design your own method of reconstruction. So this is the boy, 13-year boy, his first fracture in the cyst that was managed with this simple U-slip. And look at the cyst get healed. So how much time it takes? It's a variable. Sometimes it takes 6 weeks, sometimes 8 weeks, sometimes we have seen. Then again, after 3 months or so, he got a second fracture, and second fracture after healing, and this is how he's moving. We did nothing, and just to put it 2 times, plaster on this patient, and this cyst get healed. So we get a big series of this. Most of the time we don't fix the humerus cyst whenever you see the fractures. So this is another boy. See, the cyst is here. With one fracture, is almost cyst get healed. And if you see the functional status, is absolutely normal. So there is no need to go inside just to confirm the cyst get healed with the fracture. So we find out that most of the cysts get healed with this fracture only. But there we have seen 2 times, 3 times fracture. And sometimes even a 1 year that will 100% doesn't heal. So we get a good series of these cases, but most of the time we observe this patient and let the fractures heal with normal back slab or U slab or sometimes only pony sling. Where we prefer to do the prophylactic fixation, if you see this 12-year girl is more than 2/3 of the cyst this involving the diaphysis, and this 2/3 of this cyst is almost this thinning of the cartilage. So where we just went, just take a 1 centimeter wound on this side, curate out all the cyst to remove the simple cyst wall inside the cavity and just apply the plate. And within 4 months or so, this cyst gets healed, and this is how she is having normal function. So there another option other than observation and prophylactic fixation. When you see the cyst is lying in the proximal femur and it's almost involving more than 2/3 of the proximal area, so we tried combined for fixation as well as curate and the bone substitute. And if you see within 1 year, this bone substitutes are getting absorbed, the new cysts get healed, and this child is also walking normally. So we have seen some other patient where we use the bone substitute. This is the case where we identify the child, the girl, having chondroblastoma in the talus. And we took the biopsy, confirmed which is the lesion, and then we curated out this talus and just put the bone substitute. And this patient is having absolutely normal ankle function. So this is the case where we tried the bone substitute in the proximal humerus as well. There was no fracture. The parents were worried about, though we counseled the patient, there was nothing to do, but just we go inside, take a 1 centimeter window here, and then make a hole around this area, and curate the wall, and then just to put the bone substitute. So if you see the cyst get healed with this bone substitute inside the cavity. This is a child with pathological fracture in the neck of femur, and we just curated and put the bone cement, this bone substitutes. This is another child with this pathological fracture in the neck of femur, but this cyst was aggressive and this was extending to the diaphysis as well as extending to the epiphysis as well. So again we did nothing, fixation, just curated it and put the bone substitute. And this is after healing within 8 weeks or so. So absolutely normal function with this. So the role of steroids in unicameral bone cyst, huge cyst lying in the pelvis. If you see this whole pelvis and only this superior pubic rami, some part of the ischium and some part of the ectoderm is involved. And what we did was just only took the biopsy first, confirmed this is a unicameral bone cyst, and then we inject the subpercutaneously under the CM 160 milligram depomidol. And if you see the cyst get healed, the cyst get healed within 4 months or so. If you see the whole cyst get healed, it is closed. So we did nothing, only just put in 160 milligram depomidol inside the lesion percutaneously. So there's another patient with the chondroblastoma 80 in the proximal tibia epiphysis, but see this is in the middle. Okay, the typical finding there. So we just go inside on the medial side, make a window here, curate it on a hole. And if you see, this is most of this epiphysis lays in the posterior epiphysis, not in the anterior. And just go inside and put this bone substitutes, and this whole cyst get healed with normal cystic lesion that get healed completely within the epiphysis. So this is another patient with a 4-year with ABC in the right ischium and pubis. And here we tried, because this was painful as well, because when the child was sitting on this, he got a pain on this ischium, the whole ischium was absorbed. So we approached through the posterior approach, and we just make a window in the cyst and diathermize, hold the lesion inside and save the capsule along with this bone and put the bone substitutes. So this cyst is almost healed. This child is walking on it, but later on we find out that some of this hip got a subluxation. But still child is pain free, so she is walking on it. Sclerotherapy we don't use. We don't have available this polyclonal in Pakistan. So we don't try sclerotherapy, but we have seen same result with the bone substitute. But the people are using it worldwide. They are using 1 to 4 injection, maybe more than 4 injection as well. So this is one method where you can do this percutaneous treatment for this when your bone cyst or cystic lesions. This is what I was trained in Japan. They were doing this decannulation. They have this simple screw as well as this hydroxyapatite cannulated screw. Just make a 1 centimeter window here. They curate the cystic lesion and they just put a cannulated screw. Either simple screw or they have hydroxyapatite screws. And the concept is that once you remove the wall and then continuously decompressing the cavity, that it will heal by itself. So this is how they are treating it. We tried few cases. This is normal screw they tried. This doesn't work. So this is basically normal screw. The proximal black one and the white one is hydroxyapatite screw. So they use and leave this screw inside the cyst and make the heel, this side of the appetite heal the cyst. So they have only 15 patients where they have used in the humerus and in the proximal femur, and then 80% of the cysts get healed with this. We tried this in ABC as well as the UBC as well, but we additionally use the bone substitute in the neck. We just put a simple screw because we don't have hydroxyapatite, and most these two cysts get healed as well. But if you see this, still the cyst is there. This is not completely healed, but the disease is still static in this patient. When you go throughout, and there are some lesions where you can't treat this with observation and other methods where you plan for marginal resection even in this benign lesions. Now this is osteochondroma involving excessively into the scapula, and 2/3 of the scapula was involved distally. So definitely there's a huge mass aligned. So we just go inside and did this excision of this lower pole of this scapula. Again, the osteochondroma is very common, more common in distal femur and proximal femur, proximal tibia, humerus as well. But if you see in this huge osteochondroma, excessive mass on this arm and so exuberant that even the novel bone was not identifiable. So we just go inside and we plan for the excision in this. And if you see this, we resected all the humerus, saved the epiphysis, and put only the simple fibula, non-vascular fibula, and put this one screw above, one down. So problem happened because the stable fixation was not there, and the proximal segment go into non-union. So we put BMP, and we see this non-vascular fibula get hypertrophied as well. And then later on we put this floss plate, and if you see this whole fibular graft and proximal, this is incorporated in both ends of this proximal and distal end of the humerus. And this is how she is moving her arm. So absolutely, still there is abduction limited, but she has a normal function on this. So this is another child with 14 years with superior pubic rama and the bone cyst. We did the biopsy, confirm it. But if you see this, if you see the CT scan, only thin wall is lying in the medial quadrilateral place, and there is no more bone left on this anterior aspect as well. So we planned to do the marginal resection, save the periosteum of the whole pelvis from the superior pubic rama, and put some bone substitute to the wrap up with this periosteum to at least have a medial support so that it will prevent the lateral ACWM protrusion. So this, if you see this in the medial side, there is only an MRI, there is no medial wall present in this pelvis MRI. So we just went inside, we did a marginal resection of the superior pubic rama, preserve the periosteum, and then put bone substitute on the medial side and stitch with this the normal periosteum. And this is how this child is walking. So very rare, but we in our series we have two cases of chondromyxate fibroma, one in distal tibia and one I remember in the proximal tibia. So distal tibia, if you see this, the posterior cartilage is completely eroded, it's also aggressive lesion. So we did a marginal resection and leave the one cartilage intact and put the fibula, and if you see this incorporation whole fibular graft completely within a year or so. She is absolutely normal and walking in it. So this is the difficult case as a proximal tibia. ABC, one biopsy was done and marginal resection was done somewhere else and elizero was applied. And once they applied the elizero, they could achieve the good transport, but they had a recurrence in the cyst here. And later on they sent this patient to us, and after the discussion they did the re-biopsy again, that biopsy turned out to be giant cell tumor. And we gave patient denosumab. Somehow sclerosis was there in the cyst, but we still in doubt that this is not this giant cell tumor is the bone cyst. So we did this all scans again, and this was the condition of the skin all around. And what we did when we opened it, we realized this is not giant cell tumor. So we did marginal resection. We leave this transported bone. We release this marginal resected all cyst, preserve the joint line, and put this double fibula along with bone substitute. And we reattach the soft tissue around this. So later on what happened, this is how we put the plate and bone substitute with double fibula. But see this skin get necrosed, this all get dead, But later on we convert this into the gastrocnemius flap and ischinograft, and some part of the plate was exposed on the lateral side, so we remove the plate and let the infection heal as well. So see, this skin is healed, and this is healed fibula, double absorption of completely bone substitute put into this lesion, and somehow their slope is also maintained in the proximal tibia, and this is how she has function. It's almost a normal knee function, and all cysts get healed as well. So this is another case of chondromaxoid fiber on proximal tibia, where we did just one cardiac margin recession and just put the fibula. This is after the healing. So this is the case, and recurrent chondroblastoma and proximal humerus. Initially we did curettage and put some bone substitute, but that get recur. So we using in some cases where we use the fibula and only hang the proximal fibula with this acromen. So we leave it and just put a hole here and put a fiber tape here and let this heal. If you see, this is healed, but still she has some restriction in abduction, but flexion and other movements on the limb is normal. So this is the fibula, non-vascular fibula is healed as well. So this was the case we did 8 to 9 years back, where the cyst, this chondroblastoma was present in the head, and allograft was available at that time when we arranged this bone bank, and just curated it out, and we just put the bone allograft. So, and this is how it healed, but here some bump is also present here, but see the cyst is consolidated, and this is 8 years of follow-up. So he had absolutely normal function, still he is working on it, and he got a normal sitting in posture. So this is as one of the options where you can use the allograft as well. So this is another boy. Recently we did a 16-year boy with fibrous dysplasia. It's common. Still we have seen a few of the cases. There's a severe deformity of the varus, and see the bump and cyst, huge bone lying in the middle area here. So we just dissect out the periosteum, look at this, and we may remove the wedge right from this made of this diaphysis, correct the osteotomy and put a plate. So this is the correction we have achieved recently. This is almost 4 weeks back. So another patient with the chondroblastoma pelvis. If you see this is a huge mass crossing this middle this side of the abdomen, but 2 incisions was already made by general surgeon to take the biopsy, and they turn out of the chondroblastoma. You see this lesion is crossing the midline, and whole pelvis is also involved. So see this is absolutely another topic. So this is a huge mass absolutely involving the pelvis, and we did the CT scan. Half of the supraacetabular region was involved, half of the sphere. So we did the resection with P1 and P2, and if you see this huge mass lying in it, and this is how she is walking within 12 weeks or so. So this is hanging. So these are all options we use commonly in the benign lesions around the pelvis. So we get another 15 minutes or so. As you wish, sir. दोबारा करें. Yes, sir, please. Yes, please. We use in giant cell tumor, when we do curettage, we use in few cases where liquid nitrogen. But we have series of cases, we did around 40 cases in malignant bone tumors where the osteoblastic lesions are there. When bone is preserved there, then we use liquid nitrogen. We got a malignant series. If you got a time, I will show you the malignant bone tumors as well. So we use only liquid nitrogen where we have osteoblastic lesion, not the cystic lesion. So, okay, thank you.
Thank you. Now we are moving on the next talk by the Professor Tumor on the Earth palsy, reconstruction, decision making, and the essential steps. He is on the line.
जी इसको मैं साफ कर लूँ
Yes, sir, you can see, you can see.
अच्छा ये मेरी आवाज आ रही?
बहुत अच्छी आ रही है सर।
ऐसे अब स्लाइड लाना है। एक सेकंड में जरा ये स्लाइड ले आऊं पहले।
सर स्लाइड शो पे प्रेस करें, स्लाइड शो।
ये हमारा जो टेक्निकल आदमी है वो कर रहा है।
अच्छा स्लाइड शेयर वो सर वो शराब का गिलास रखा हुआ है सर, उसको जरा क्लिक करेगा वो। और सर जावेद हंस रहा है, जावेद इकबाल सर हमारे पास
इसको कहते हैं जनरेशन गैप।
सर हमारे पास इंटरनेशनल गेस्ट बैठे हुए हैं, मार्क सिंक्लेयर फ्रॉम द यूएई एंड प्रोफेसर बुनी यिल्मास फ्रॉम द Ankara, Professor Inan from and Professor Mahir from the Istanbul. They welcome you, sir.
Great. Let me start with thanking Anish Bhatti for inviting me for this talk. I so badly wanted to be there physically among you, but my children were visiting from US and they were leaving one by one in these days. So thank you, Bhatti sir. So my talk today is vehicle collection bus policy. Let's start with a quick review of anatomy. Brachial flexors are formed by 5 groups starting from C5 to D1. C5 and C6 groups come together to form the upper trunk. C7 continues as the middle trunk. C8 and T1 come together to make the lower trunk. Then each trunk divides into anterior and posterior divisions. Divisions are behind the clavicle, and all the posterior divisions they come together to make a posterior part. This terminology of posterior, median, lateral is a reference to their position to the brachial artery, axillary artery. Anterior divisions of upper and middle trunk, they come together to form the lateral cord, and anterior division of the lower trunk that continues as the medial cord, and then each has its branches. So this is a more detailed anatomical drawing. You see C5 and C6 roots, they take fairly long roots, and the lower roots are more transverse and shorter roots. Roots and trunks are above the clavicle. Our divisions are behind the clavicle, and cords are below the clavicle. There are 2 other structures which are important to note. One is the phrenic nerve, which lies on the anterior surface of the subcutaneous anterior, and accessory nerve, which lies on the under surface of trapezius muscle. This drawing is necessary to understand because when we talk about pre-ganglionic as post-ganglionic, it is the sensory nerve root ganglion which we are talking about. Is DNA is proximal to that ganglion, that means roots are worse and it is bad. And in post-ganglionic region, there is always a possibility of repair. So this is one very primary and basic description, that is pre-ganglionic and post-ganglionic region. Below the clavicle, the brachial plexus is behind the pec minor. Once you take the pec minor, all get cut it. This is the picture legislative picture. Median nerve is formed by contribution from the medial and lateral cords. That cord continues as on the subcutaneous nerve, and medial cord continues as a ulnar. Let's start with the evaluation. In evaluation, we want to determine the level of the injury, both vertically and horizontally. By vertically, I mean what roots are involved, C5, C6, C7, C8, or P1. By horizontal, we mean whether the lesion is at the root level, trunk level, division level, cord level, or in the branches. We also want to determine if possible whether the lesion is pre-ganglionic or post-ganglionic, and also the grade of lesion, which we can call it whether it's neuropraxia, extradermal, or neuroendodermal. Evaluation essentially entails history, physical examination, and some imaging. Imaging is generally plain X-ray of the shoulder and the neck. And occasionally we might be benefited with EMG studies. In physical examination, actually the complete physical examination and repeated neurological examination is the key for diagnosis and prognosis. More than any study, including MRI or anything, it is your physical examination which gives you the best information. This kind of a performa is good to keep your record and to compare the repeated physical examination and your neurological findings. We should be familiar with the prenatal risk factors which causes this kind of problem. Those are not for gestational age infants. Previous delivery resulting in brachial reflex palsy, prolonged labor, breech delivery, assisted vacuum or forceps delivery, digital deliveries, shoulder dystocia in vertex presentation, and digital or market extraction in beach presentation. Diagnosis, as always, depends on history, physical examination, and occasionally X-rays. In history, we should be inquiring about how those possible risk factors for POSPCON, which is especially gestational diabetes, maternal weight gain, and delivery-related factors like gestational age, induced delivery, prolonged labor, shoulder dystocia, instrumental delivery, and birth weight and stress. We should be also inquiring about the description of the appearance of the limb at birth and any changes in the limb since delivery. Lastly, assessment of the infant's overall development, including feeding history, weight gain, and other medical conditions should be inquired. In physical examination, start with head and neck. In any evidence of articulus, it may be secondary to birth trauma or positioning to protect the affected leg. In the face, look for possible Horner syndrome, which is characterized by ptosis, meiosis, and anhydrosis. In the chest and back, asymmetric chest wall motion with the acceleration indication a hemidiaphragm paralysis and a phrenic nerve palsy, which is usually associated with C5 intervals. One should also notice scapular ringing or absent rhomboid function. This again is confirmed with the C5 avulsion and indicates preganglionic injury. In the physical examination of the upper extremity, posture of the limb is important. In C5 6, or even with plus minus C7. Palsy present with shoulder internal rotation, elbow extension, forearm formation, and the wrist flexion, the usual classical waiter's hip position. In C5 to 8, T1 are global palsies that have excessive hypotonic upper leg. Humerus and cervical fracture are calculated to detect tenderness and the bony callus of a back fracture. One should also examine for the active and passive motions. Active motion scale, or called AMS, is a validated assessment tool used in infants with birth palsy to quantify active joint motion. And that determines the extent of the nerve injury and assess recovery. Toronto test score, which incorporates elbow flexion and elbow, wrist, finger, and thumb extension, is also used to evaluate infants and predict the need for surgery. This is the Toronto muscle test score. It rates the child's ability to perform 5 movements against gravity. That is the elbow flexion, elbow extension, wrist extension, digital extension, and thumb extension. Scoring ranges from 0 to 2, reflecting absent movement, partial movement against gravity, and full anti-gravity movement with total score, possible score of 10. Toronto test score at 3 months of at age at about less than 3.5 indicates need for microsurgery. This is a picture of Harmon syndrome, which is a small pupil, ptosis, and anatosis. And this is a pathophysiology. Why that is important to note, because synthetic fibers exit along with C8 and D1 roots, and then ascend again along the vessels to the eye for the eye control. And if C8 and D1 roots are burst, that causes this Harmon syndrome. So if Harmon syndrome is there, that is generally indication of a root avulsion of C8 and D1. These are some of the happenings associated with the birth palsy. Birth palsy is proximal paralysis. It is paralysis of C5 and C6. Child will present with extension, restriction, and internal rotation of the upper extremity. This is the clunky paralysis, which is a distal paralysis. Active clunky paralysis is very rare. Generally, it's a global paralysis where proximal roots have recovered and distal have not. One interesting thing to know about clunky is that she was refused admission in a medical school in USA because of gender, and she had to travel to Holland to get medical education. So this women's head is not very good. This is the Mallet system of evaluating the shoulder function in a child. We check the global adduction, global external rotation, hand to neck movement, hand to spine, and hand to mouth, and rate them along as grade 2, grade 3, and grade 4. In older children and adolescents, assessment of children and adolescents with birth palsy, we start with asking them as well as their parents about their concern regarding use of their upper extremity. Because by then they come with certain concerns and their certain questions. The child cannot do this thing, or the child cannot perform this function. That includes the parents and functional limitations. Parents of toddler and young children should be asked about their ability to perform age-appropriate activities of daily living, such as feeding, dressing, and child independence. Older children and adolescents should be asked if they can participate in sports and other activities. Shoulder abduction internal rotation contracture and elbow flexion contracture and forearm supination contracture are among the most frequently observed deformities in older children. This is one example of older children with palsy. You see internal rotation of the upper extremity. There is a limitation of abduction, and if you see the patient from the behind, you can see some elevation of or winging of the scapula. By end of your physical examination, we should know that what is the level of the injury. If it is a root patient cannot check the shoulder, that means lumbar involved, and functional serratus will be checked. At trunk level, external rotation of the shoulder, that is suprascapular nerve is checked, and at the third level, it is adduction of the shoulder. So there are three movements. You ask if a child is old enough to understand that he should reject the shoulder, he should externally rotate the shoulder, and then he should adduct the shoulder. And then at the back, after you are familiar with examination of radial, median, ulnar, and musculoskeletal nerves. These are different groups which are associated with certain movements. C5 is the shoulder abduction, C6 is elbow flexion, C7 is elbow extension, C8 is finger flexion, and T1 are intrinsics. Grade of the ligament, if possible, we want to know whether it is just neuropraxia, which has almost 100% chance of full recovery, or it is accidental pieces, which depending upon the severity of the ligament will have some deficit, or it is neurotomesis or root avulsion. Root avulsion, which is a preclinical lesion, implication is that it is irreparable. Now, Nalkas has divided the palsy from the treatment point of view into four groups. Group 1 is C5 and 6 palsy, and there is about 90% chance of spontaneous recovery. Group 2 is C5, 6 and 7. Group 3 is flail extremity with Horner, without Horner syndrome, and Group 4 is flail extremity with Horner syndrome. Now, examination, at the end of the examination and investigation, now we have to decide which infant child needs surgery and who is the surgical candidate. Examination at 1 month. If a recovery is evident, one should keep observing. Total palsy with Horner syndrome at 1 month as a poor prognosis, and one should consider early surgical intervention. Examination at 3 months. Any bicep recovery is evident, one should keep observing. If there is no bicep function at 3 months, one can further investigate with EMG and MRI. This is a natural history which gives a candidate. Bicep recovery in first 2 months, one can expect full and complete recovery over 1 to 2 years of age. If there is no recovery in 5 to 6 months, that is the candidate for surgery and should have microsurgical reconstruction. Clark Cookie tested that child can take flex his elbow and take his hand to his mouth. Partial recovery between 3 to 6 months, but I think that's an important observation. If there is a partial recovery by 3 to 6 months, there would be some permanent limitation. With a growing year, internal rotation contracture leads to humeral deformity, which has its own implication. We'll come to that later. So these are general indications for surgery in birth palsy. At 3 months of age, if it is a flail limb with Horner syndrome, or frontal test score is less than 3.5. AMS score less than 5, or failure of transfer state 4 to improve since the age of 3 months. At 9 months, failure of cookie test, the patient does not have a bicep and enough bicep strength to take his hand to his mouth, that is an indication for exploration of great reflection. Before surgery, our treatment includes our objective of our treatment is to protect the vector, maintain the range of motion by range of motion exercises. Bracing is occasionally helpful, but in my setting, it's very difficult to make a small brace or having the patient agree to put their infant in a brace. Once you decide to operate according to those indications, you can do 4 things. You can do neuralisis, you can do the neuronal section and reconstructed nerve grafting, or you can do the nerve transfer. Nerve transfer have greatly changed the scene of reflexive injury. This was a general surgical exposure described in the books, but I prefer this injury. You subtend the angle between the clavicle and sternocleidomastoid, and that is a main exposure for the supraclavicular reflexes. If I have to go infraclavicular, I make a separate incision. I can connect these two incisions also. To me, this is much better, cosmetically, much better, anatomically, much better approach. Once you explore it, you will see the injury above the clavicle. Clavicle can be moved up and down, or it can be optimized if needed. Now these two things are important. What's our reconstructed goal? For babies with a lesion restricted to upper roots. Reconstructed roots are almost similar to adults. That means you address the shoulder movements, elbow flexion, and wrist extension. In babies, it's global process. The goal of the neuroreconstruction differs from those recommended by adults. Here we go for restoring the hand function. Because in these infants, if you neuritize the median nerve or ulnar nerve, children do get the hand function restored. So that purpose, if needed, one can use a ruptured C7 to above C8, or one can use even contralateral C7 to improve the hand function. And that's one fundamental difference in butt palsy compared to the adult reflex injury. Priority should be given, especially with attention to median nerve, because infants can recover useful hand function after nerve grafting and nerve transfer. These are the common cervical steps. In C5, C6 rupture, accessory nerve is transferred to suprascapular nerve to give you shoulder abduction, sternal rotation, and nerve grafting from C5 to posterior division of upper trunk, that means the shoulder abduction, and C6 to anterior division of upper trunk for the elbow flexion. If it is C5, C6, C7 lesion, strategy depends on number of available routes, primarily, and it is generally combination of nerve grafting and nerve transfer. Priority will be given to the elbow flexion, and shoulder function can be restored by secondary muscle transfer like psoas muscle transfer. If it is a total reflective palsy or global palsy, strategy again depends on the available routes primarily. If limited number of routes are available, prioritize the elbow flexion and hand function. Ipsilateral or contralateral C7 can be considered to neuritize the median. C5, C6 version of the nerve transfer. Nerve transfer has really changed the scene of brachial plexus. If a C5, C6 version, excessive nerve is transferred to suprascapular nerve as before. A branch of long head of triceps or subscapular nerve to auxiliary nerve to motorize the delta muscle, and what we call overtime transfer. We borrow a bundle from the ulnar nerve and transfer it to branch to the biceps, and also borrow a bundle from the median nerve to neurotize the nerve to brachialis. This is a great improvement and probably better than the exploration of the brachial plexus and nerve therapy. Now the late is concerned. If we have passed that period where we will consider exploration, nerve therapy, nerve transfer, now it is a period where we would be addressing the sequelae of blood passing. And usually it's internal rotation, deformity of shoulder, lack of elbow flexion, and then the lower down in the hand and wrist. For shoulder, most commonly done procedure is the release of internal rotation contractors by release of scapularis and transfer of latissimus dorsi to infrascapular. I do a different from a scopola procedure, which is generally described in the book. I make an incision along the posterior pubic fold, like we do otherwise to armrest or okay. I think we are back. Sorry about these technical glitches. So this is how I perform these are subscapularis. From this incision I can harvest the dorsi and these subscapularis, and then because you cannot do it through the anterior approach, the way we can harvest the dorsi and mobilize it, and then transfer it under the delta to the infraspinatus. And this is one example. The internal rotation deformity of the shoulder, lack of vibration, and this is the vibration of transfer of latissimus dorsi to infraspinatus. This is we talked about being a humeral joint with the long-lasting internal rotation. Generally, there's linear get deformed and head subluxus posteriorly, like in this case. Coleman demonstrated that tendon transfer improved the overall shoulder motion but do not reduce humeral head subluxation or enhance humeral joint realignment. So for this purpose, He advised early arthroscopic capsular release and subscapularis stenotomy and was successful in obtaining reduction after humeral joint subluxation in his patients. If there is already deformity, then instead of working on the joint, we generally recommend humeral osteotomy to observe the locate. It's a very gratifying procedure, there is immediate result, and on out of internal patient, with that some affection is also improved. For elbow flexion, we have three choices, either standard flexoplasty, you can use the distal dorsal or pectoralis major to motorize the elbow. Most commonly done procedure is elbow, is a standard flexoplasty, where we move the common flexor coordinator region 4 to 5 centimeters proximally to the humerus. And it generally gives a reasonable flexion. It is generally desirable that one should end up with about 30 to 40 degree flexing contracture. From that position, child should be able to flex about 90 degrees. This is the distal dorsal flexoplasty. One can harvest the distal dorsal muscle. One can take a skin with that if needed and use that for elbow flexion. This is a case example of distal dorsal, and he's trying to show his muscle and his ability to flex his elbow. This is pectoralis major elbow flexoplasty. Pectoralis major muscle is harvested. Its insertion is detached and then that is attached to the clavicle. Rest of the muscle is made into a tube and attached to the tendon of biceps at the elbow level. One should not forget the role of therapist. Therapist is very important in all of these procedures to minimize edema, prevent contracture and deformities, manage sensory loss, monitor and integrate sensory and motor recovery, functional rehabilitation, and emotional support to the patient and the family. Control of edema is done by massage, agitation, and pressure gradient garments. Pain control is a pharmacological agents and surgical intervention and TENS. Splinting is important with all these procedures, especially on the shoulder. One needs the proximity abduction splint, and lower down one would need the wrist splint and behind and posterior web splints, and you need the therapist to maintain the range of motion. I will end up here, and if there's any question, I will be glad to address those.
Anyone has a question from the Professor team?
All right, if not, one should replicate this picture that we don't know what he's at photograph. But he has
सर थैंक यू वेरी मच सर वो कहते सर सुमन को फोन या तो सबको समझ आया पूरा आ गया कुछ नहीं अमीन चिनार से कुछ पूछना चाहता है अमीन चिनार डॉक्टर साले डॉक्टर रमीश फ्रॉम यूएसए इज आस्किंग क्वेश्चन सर
If no one else is asking, Dr. Chima, thank you so much for the talk. We met last year at this conference, and I'm excited to have you involved here. In your plexus work, I'm very curious for when you do get the shoulder dislocations, you see many more delayed patients than we do. How are you managing the posterior dislocated humerus in the delayed patient?
If it is just subluxation, then sometimes I do try to address retroversion of the penile by osteotomy at the neck of the recaptures early. But if it's an older patient, and then we would leave it there and do the human osteotomy to bring the arm out of the. So if I have to work on the shoulder, then I would like to address the pediatric version and also the soft tissue and capillary.
आप पूछना चाहते हैं क्वेश्चन?
इधर नहीं इधर हो नहीं वीडियो तो इधर से चलेगी
Thank you very much. It was a great honor
वीडियो इधर से
to
चलेगी
listen to you बार-बार और वैसे
जी जी लिंक आया था मैं देख लिया
But it is as complex as the basic accessibilities that you can't understand.
Camera is in front.
Thank you.
Professor Ashok Johari is online. Please get him on the link, please. Ashok Johari sir.
सामा एजमे पे करो
From India, Mumbai. His class is online. Syria.
एजमे पे कर दो स्विच डीआई पे करो दो नंबर की ऑडियो ब्लॉक
Professor Johari. Assalamualaikum sir. Good afternoon. So your friends are here, Professor Mark Sinclair, Mono Inan, and Gulshan from Turkey, Ramesh from USA. You please go ahead, please.
The pathophysiology is a private commando causing osteoclastogenesis and a low oxygen.
Ji, Professor Johari, can you listen us?
And to maximize this, yes, but at the outset, I am grateful to the Pediatric Orthopedic Society of Pakistan for this invitation. Now in 2026, really, the latest pseudoarthrosis of the tibia is definitely a challenge, but a little no more because we know so much more about it. The key facts, the incidence is between 1 in 140,000 to 250,000 live births. The pathophysiology is a fibrous hematoma causing high osteoclastogenesis and a low oxygen. It is associated very often with neurofibromatosis 1, 38 to 90% of cases. Then the key challenges are persistent non-union, reed fracture, and limb length distribution. Clinical features is frequently identified in the neonatal period. The characteristic deformity is an anterolateral growing of the distal leg, Morrison ossification, provide diagnostic clarity and suggest an underlying genetic etiology. There is a late onset. We're talking of neurofibromatosis. It's a tissue dysplasia. Dysplasia affects both mesodermal and neuroectodermal tissue. Its epidemiology occurs in approximately 1 in 3,000 live births worldwide. The inheritance pattern, 50% demonstrate autosomal dominant transmission, 50% arise from spontaneous mutations. There are two types of chromosomes which are associated. Neurofibromatosis 1 is chromosome 17. Largely same manifestations, the capital spot, which is the diagnostic hallmark, and associated tumors like optic gliomas, malignant peripheral nerve sheath tumors, and plexiform neurofibromatosis. Now, neurofibromatosis 2 is because chromosome 22. Skin cutaneous manifestations are minimal, but there are associated tumors found in the central nervous system. Neurofibromatosis 1 are well-known: cortical erosion, limb deformities, long bone abnormalities, pseudoarthritis formation, and fibrous lesions. Radiological findings in tibia pseudoarthrosis is of course deformity, angular deformity, typically the propagator which is present at the junction of the middle and distal thirds of the tibia. also classified congenital pseudoarthritis of tibia into 4 types. Well, the classification right now is not very important, but the type 4 atrophic variety is the common variety and has a worse prognosis. It requires complex management and has a high refractory. L. Rosacea actually divided CTD into 3 types depending on the bone age geometry, mobility and the pseudoarthrosis, and prior surgical history. Well, in the Chinese consensus, it was found that surgery should generally be deferred until at least 3 to 5 years of age, and outcomes improve with delayed intervention. Well, this is a debate which has been going on for a very long time. So this is a proper classification. Type 2 involves actually thinning of the cortices, type 3 is sclerosis, and type 4 is the atrophic type of pseudoarthrosis. This is a 5-year-old with neurofibromatosis type 1 demonstrating established pseudoarthrosis with atrophic bone ends, which is spindle-shaped and pale healing response. L-Rosacea classification here, atrophic bone ends, mobile pseudoarthrosis is the type 1 but without a previous surgical intervention. Well, when you have surgical intervention, we classify it as a type 2 for sure, so with or without retained hardware. The type 3 is broad bone ends with stiff pseudoarthrosis and with or without previous surgical intervention. The treatment options in congenital pseudoarthrosis of tibia. Well, what are our challenges? There are a lot of challenges. The main thing is to get the bone to heal. The poor vascularity and osteoinduction capacity is the problem. We need a good alignment of the tibia and the fibula to prevent stress fractures again. We need to support this bone with internal fixation so that protection remains for a length of time internally. Then the ankle alignment is important because the fibula has to be brought down to restore the ankle joint and then prevention of refracture into the tissue. Well, about healing, we need debridement of the fibrous pseudoarthrosis tissue between the bone segments which are associated with the pseudoarthrosis. We need to create a healthy vascular bed for bone repair. We need to promote osteogenesis and we need to control the overactive bone reduction catabolism. So alignment is important. We need to fix the bone to appropriately to achieve rigid stability in the medial case. The global alignment of the leg is important and the ankle alignment as I mentioned is also important. To prevent refracture, well, the tissue has to heal well, the bone has to be stable. We have to achieve a good quality healing, the bone diameter has to be good. The intramedullary rod supporting the full length of the tibia is required to skeletal maturity to prevent occurrence of refracture and deformities of the leg, and then protection against fracture by means of bracing. Well, this is the way we do modern technique of intramedullary rod fixation with bone grafting and rod values a step ahead to put periosteum around the bone graft to wrap it up in the periosteal sleeve, the so-called periosteal grafting. Well, use of BMP and bisphosphonates in the surgical intervention today. These are the current trends in periosteal graft formulation by me. Well, different surgical techniques, intramedullary rodding, telescopic rod, the fixation-to-wall rod, or a static nail is placed through the medullary canal for stability and refracture prevention. About a healing rate of 70%, the union time is long, about 8 to 9 months. Devices should be retained as long as possible to prevent refracture. Areas of external fixation, the ring fixator enables distraction and compression, where it stabilizes the pseudoarthrosis area and you can compress the pseudoarthrosis site. The healing rate is much better, 89% with a union time of 7 to 14 months. This is the highest single method union rate. It also corrects the ligament discrepancy and the angular deformity. Well, the table summarizes the marking below, summarizes the rates with the combined intramedullary rodding as well as with the Izaro technique. The union rate is 85%, but the healing time is faster, 5.62 months, and the refracture rate dropped by Now here's an example of a patient, a 2-week-old, case of CBT. You can look at the right tibia with the lower third, middle third, lower third junction. There is a pseudarthrosis. This child is 2 weeks old. And he has the classic cafe outlet spot which can be appreciated. The deformity is present. This is 2 years later. This is the situation. Atrophic bone ends. This is about 6 years later, 6 years and 8 months old. When no treatment has been carried out, he uses the brace and manages to walk. The final presentation at the time of surgery here, this is surgery. The area is exposed, the pseudarthrosis is exposed and pressed up. The blade actually, the periosteum is completely excised, all the hematomatous tissue is completely excised around the tibia and the fibula is exposed. The fibula is seen in the upper side of this picture and the tibia here, the pseudarthrosis. And then we pass on the patient who was brought and a plate, utilization plate is attached. The fibula is also fixed by means of a nail and a cross unit is actually developed between the tibia and fibula by means of bone grafting. You can see the bone graft in the interosseous space, and this is the healing as it is proceeding. 2020, 2021, it is well healed. So the fibular fixation, the tibial fixation, the neutral direction to prevent rotation, and the bone graft in the interosseous space all become very, very important. You see that there is a valgus deformity in the ankle, and this needs restoration. So we put in a screw for median heavy epiphysiodesis, and this allows a good horizontal ankle alignment finally. Like this is a follow-up of 3 to 4 years here. After the screw was put in, it took a long time for the screw to act, slow speed of flow, but clinically this patient is doing well. He has a short knee, which will be tackled later on. Another example here, this is a newborn baby, but this is around a month old and 3 months old on the left side. But 2 years later, 3 years later, one sees that there is bowing, there was fracture, there is bowing, anterolateral bowing with a protruding deformity, but the area of the future pseudarthrosis is getting demarcated very well. The tibia is narrowed in that place, and you can see angulation which is happening, and ultimately there is a fracture there. Well, the fracture heals temporarily with a plaster, but again refracture. As a reason, some surgeon actually did a bypass grafting here using the same ipsilateral fibula. A bypass graft is put in, but the fracture persists. The fracture is persisting. So this is 5 years after birth. This is the situation. Deformity. In fact, his father also has anterolateral bowing of the tibia, as shown on the left side. His father's picture, and this is the child on the right side. Well, presentation in 2022, when he was around 12 years old. Deformity is getting severe. The fracture is not healed and the bowing is increasing. 2022. And finally, comes for treatment in 2024 at the age of 14. The deformity is very, very significant. Virtually 90 degrees of bowing, anterior bowing is present. The procurator very easily appreciated. Shortening of about 4 to 5 centimeters which is present here. Well, at surgery, the angulated area is exposed, dissected out, that is the bypass graft which was put in on the top. Below is the tibia. Well, the actual fibula is seen on still below the side of the picture, lower side of the picture. The tibia is osteotomized. The overlap which is present to straighten the tibia, so that is all taken off. Well, you have these fragments now in place, in position. The nail is put in, bone graft between the tibia and fibula, and the neutralization plate, the epirod which is there. And the healing which takes place, this is the most current picture. There is a crossing between the tibia and fibula. The tibia has a rod as well as the neutralization plate. So it is doing very well. This is the technique of cross union, which is currently the most favored technique. The vascular fibular graft, well, orthopedic surgeons really are not very, very enthusiastic about it, but the fibula can phosphorylated protein, the two types, RHBLP2 and RHBLP7. Both of them are used to enhance healing. This phosphonates to prevent osteoclasis, damage or chlorhydronic acid can be taken. And combinations can be taken. Now, mesenchymal cells along with a collagen scaffold and platelet-rich plasma clots can be used to promote osteogenesis in sites with impaired bone formation. And very early reports are coming up. The first report is from Karachi in 2024, where bone formation and healing of the tuberculosis were demonstrated, and then there are a few other reports. Well, guided growth, the role of anteronatal distal hemiepithelial research. We have a few papers from 2017. The most recent is by Zhao from China. 18 patients using a U-shaped staple. The deformity is corrected to a large extent and retraction is prevented. The induced membrane technique has also been used in CPT. Two stages, just like with all induced membrane. The pseudoarthrosis area is dissected. A cement spacer is put in. The periosteum is allowed to form over it. The cement spacer is removed and bone grafts are put in. So that allows the bone healing to take place. But the latest genomic and molecular landscape in CPT, whole exome sequencing can reveal pathways and genetic sort of basis for pseudoarthrosis. So there are variants in both the LF1 gene and other ossification gene. This allows us to do the therapy according to the genotype, and we can give targeted drug intervention for specific pathways. And then exosomes which are involved, which inhibit osteogenesis. So these can be targeted by exosome targeted therapy and investigation. So these are very beginning stages of these therapies, and this will come in. They're going to move CPT towards a precision medicine paradigm. Well, the healing rates, of course, are the best with Elizaro, or today with the cross-union technique, it's 100% with a low retraction rate. Combined intramedullary rod and Elizaro reduces the union time. The BAP augmentation is useful, and BAP with bisphosphonates also help. So what is the future in CPT? Regenerative medicine, as I mentioned, exosome targeted therapeutics to restore bone formation, using osteogenic organoid therapies, using the stem cells, and then pluripotent stem cells to derive osteoblasts for patient-specific grafts. Precision genomics, where drugs can work, novel therapeutic targets can be used, and then surgical. So our surgery combined with biologics and then 3D patient-specific implant and scaffold and standardized consensus treatment algorithm. So the future of CPT management lies in integrating biological, genetic, and surgical innovation into a unified patient-specific treatment pathway. So thank you very much for your attention. I wish to thank Dr. Mukherjee very much who did a lot of this research, and thank you again for the invitation. I would welcome any questions and we can have the discussion.
Thank you, Professor Johari, for a nice talk on CPT. And any question from Professor Johari from audience?
Professor Johari, can you listen, sir?
Yes, I'm listening.
Thank you, Professor Johari. Your friends are here, Mark Sinclair, Sunil Yilmaz, and Gulshan, and Mohan and Ramesh. And if you are our student want question, please, question. Professor Guni is asking, given the mic, please. Professor Guni Yilmaz from Ankara.
Thank you, Dr. Johari, for the presentation. My question is about lengthening after you get healing. So I had a couple of patients where I thought that the bone is a good quality, but when I started lengthening, I got an osteoarthrosis proximally. So what is your criteria, to make a good quality lengthening in a previous osteoarthrosis form? how we decide. I think we have to be careful because some cases the psoriasis is very localized, but it can be a generalized disease. It can be affecting the whole area. That is very, very likely in many cases. Fortunately, I have done a fair number of measuring but not had this problem which you are mentioning. We have to keep away from the site of the psoriasis process. So we will do a leveling much, much higher and do it in the metaphysical segment, upper area wherever possible. We will try to avoid leveling from any other site. Maybe if you are worried about the bony dysplasia affecting the whole area, then one would like to investigate maybe by means of MRI or MR angiogram to know how the vascularity of the area is. Fortunately, I am not encountered this problem and we have done leveling and never had a psoriasis again. So I think it will depend on whether the psoriasis is localized or generalized conversion.
Dear Dr.
There is a question from Dr. Madam.
This is Moana from Istanbul. Hi, how are you? And my question is, usually for the psoriasis is too distal than the close to joint. Do you pass the joint in your surgery because now the PGT mini techniques nobody uses the same, but for the stability when you use the cross joint fixation from the calcareous to the teeth.
Well, I have very rarely used this and much long ago. I can't recall using it in the last 20 years or so. If you use India, maybe you can fix the foot itself and try to get your every rod right down into the epiphysis of the lower teeth and supplement it with means of a plate, the neutralization plate that gives you better stability. So I think with the use of plate as well as the every rod which really comes down to the epiphysis, right up to near the articular surface. I think there is no need. I personally have not felt the need to go through the calcareous into the area. I have not done it now for at least 2 decades or even more than that.
So, hi Dr. Johari, this is Aisha.
This is Dr. Aisha from the NS Hospital.
Yeah. So thank you very much for this very nice talk. The case that you showed, which was Crawford type 4 with a tapered end bone. So for this one, like according to the Pellis concept, you don't really remove the tapered bone end and just get rid of all the hematopoietic tissue circumferentially. So do you follow the same thing, like don't really compromise on the bone and rather remove the periosteum and then all the hematopoietic tissue and try to achieve the cross-union?
The idea is to get stability in some way at the psoriasis site. So what Pelli does is probably like telescoping the fragments together, and he doesn't bother about this. If you have a very atrophic end and the end can fit into the proximal fragment, you could do that. For me, the criteria is vascularity. So I would like to section the tibia find good vascularity coming up and a stable broad surface, end-to-end surface. Shortening is secondary, you can always lengthen it, or you can do it at the same time. The lengthening, you can put a irregular fixator and do it. But good vascularity and a stable bone surface, personally I think those are the more important, along with the cross-union. So I excite the atrophic end.
Thank you, sir. There is another question from Dr. Omar Said from the Lahore Prediatric Hospital.
Thank you very much for your presentation. I'm Mahir from Turkey. What is your post-operative protocol after the removal of the external fixator or healing of the bone? How long do you use orthosis to prevent inflammation?
Well, I use it for a very long time. At least initially, I think it's full-time there. Till they are satisfied that the union is good and the bone quality is good. So if you can see medularization, there is a good medulla present and a good healing. The potassium is good. I may allow the child out of the breast in the house environment. And gradually increase that detailed skeleton ultimately. We tend to use the breast for a very long time, at least in part.
Last question from the Dr.
Hello, Dr. Jory. It's a wonderful talk, and I agree with you that perinatal crossing is the way to go. Regarding the bone substitute that you use, so in our South Asian population, bone oxidant proteins, especially the 7 is in excess of 1 lakh or 1,50,000. So, what is your experience in the poor population of the bone graft? Because we have recently done some cases using bone substitute and limited PDA graft, and we are seeing almost some good results. How is your experience, and what do you do to substitute bone graft?
So I use BLT only in very, very rare cases, where we have had failure, or either somebody has operated, or our cases generally now I can't recall we are having a failure in the last 5 or 6 years. But these cases, which are recalcitrant, which have had previous surgery, I would make use everything, and that is where I use gain. So I use it sparingly, it is not that we use it commonly. So that is where I stand. And we are getting good results without even BLP.
What is your usual graft protocol? Do you use iliac or from the pediatric side? What is your graft protocol?
Yeah, both we have tried. We have also done some years back. We did a lot of on-leg grafting. So we used to take the tibia and put a tibia sort of a strap by the side. But since we started using cross-iliac procedure, mostly the iliac crest and the iliac wing, the wing of the iliac from where we take the graft. So we are not resorting to tibial struts anymore. The tibia was on the graft. What we were using was a part of the tibia as on the graft, and supplementing it with cancellous bone. So that was as a supplementation we used to put the cancellous bone everywhere. But now we typically use the cross-iliac cancellous bone between the tibia and the. We are not taking tibia anymore.
Thank you, Professor Jory.
Thank you, sir. Thank you very much for the very informative talk. And now we will proceed to the next talk from the Professor W. Saidu on the limb salvage and soft tissue tumors in children.
So, thank you very much again. So we'll start from where we left.
So you can.
So we'll start with again the part we left. So we'll start with the malignant bone tumors and the reconstruct options. It's not working. Pointer with that. So we tried all options we have. There's an extensive osteosarcoma in the proximal humerus. Already received chemotherapy, but that doesn't work, and the tumor get progress during that 6 weeks of time as well. So we go inside and just did the wide margin and put a cement space. You see this whole humerus is almost just distal part is left around because this tumor is extending down there. So all neurovascular other than the radial nerve was all resected, this spared, and we put this some cement spacer here. But we see is a proximal humerus, whatever the reconstruction do is all depend upon the soft tissue to be left. That will the function you will gain. It is not the option of reconstruction you will put on. Either you put the fibula, either you put the nails, spacer, implant. The results will be all depend upon the soft tissue you left around. This is another patient. I didn't put this pre-operative as well, but we put this proximal fibula, and he was playing cricket with this hole, but he got a recently fracture around this. So we recently plated this one. So we used a couple of these hanging shoulders along this proximal humerus. This is again Ewing sarcoma. See, it's not necessary that every pathological fracture in malignant bone tumor should be fixed. So you got a pathological fracture here. So we did nothing. We just sent the patient with the biopsy and confirmation for this chemotherapy. If you see this chemotherapy effect, all the tumor get consolidated. Fracture healed. This is how you can check the response that once the fracture get healed, it means the chemotherapy is very much effective and you can do this limb salvage in the pathological fracture as well. So this is the wide margin, took the fibula and just do the shoulder orthodesis with only 2 screws. So this is another patient with proximal ulnar, Ewing sarcoma with the chemotherapy whole get reconciliated and all the soft tissue component get resolved. And we tried this non-vascular fibula. If you see this, both the ends that get healed, and this child is having more than 5-year follow-up and disease free. So this is another boy with 10-year Ewing sarcoma. If you see this, no ulna is visible, nothing is there, but after the chemotherapy, this ulna get reappear. And look at this beautiful chemotherapy effect when you have extensive Ewing sarcoma. And what we did, we just went inside, did the margin resection, put the same dissected whole ulna till the wrist, just save the olecranon where the tumor was absent, and put into the liquid nitrogen for 20 minutes after removing the soft tissue from this ulna and did the tension band wire. So again he went for radiotherapy. During radiotherapy he got a fracture here. Even that fracture was healed with this, and this is functional outcome he is having. This is absolute normal function around the elbow. So there is another patient with 11-year girl with osteosarcoma femur, and this is post-chemo X-ray. So we went inside. We see that this is still the epiphysis is somehow spared, so we preserve the joint. We did the free freezing, remove the middle part of this tumor, remove the tumor from the bone, and did the liquid nitrogen. So this was the hair. We remove all and we put this double fibula in this case. So we see this, we took both the fibulas from both the sides, but fibula was very thin, but still we put this. So both of these get healed, and this child present with this plate breakage and this fibula, distal fibula get fractured after 2 years. But if you see this proximal end of this both double fibulas, this all healed, even both are get adhere with each other. So we went inside this and then just fixed this area and put the bone graft now. And if you see this, we tried BMP in the graft area and we put this BMP in this after saving the periosteum. And within 1.5 years, you see this whole fibula getting reappear on this side. So this is how she worked. So definitely we also see in young patients huge masses like this secondary chondrosarcomas with multiple enchondromas and Maffucci syndrome. So huge enchondromas in the hand. So we just went inside and removed the disease to this fingers, and this is how we just spare thumb and index finger to preserve the function. So this is another case with secondary chondrosarcoma clavicle. Already was operated somewhere else and he was referred with a huge mass extending to the neck, cervical spine, chest, rib, everywhere. So we did the MRI. If you see this extensive mass just attached with the sternum and extend to the neck. And see this carotid also getting compression with this mass as well. So we just went and did the resection. And he had a more than 6-year follow-up. And he's from Savat. He's sending his pictures. He has the METs twice. He was operated for thoracotomy for the METs as well. But still he's having disease-free life. So adenocarcinoma, very rare in children, but it's still common in diaphyseal lesion. When you're expecting there's some diaphyseal, look for the adenocarcinoma. So in this case, we did the pedicle freezing. We did the osteotomy in the fibula, and just went inside and put simple plate, use the same bone. And this one another case with proximal femur osteosarcoma, and we did wide margin, preserve the trochanter, hold the femur till the knee, dissected out, remove soft tissue tumors from the bone, drill multiple holes in the femur, and put it in the liquid nitrogen for 20 minutes, and did this process composite with this liquid nitrogen. So even with this trochanteric osteotomy tension band, this get healed And this is how this child was walking. And this, I leave this videos. So this is another case. With this is femur, this is for humerus. And this is for femur. If you see this hole we did, but in this case, problem was that the chemotherapy doesn't work. So chemonecrosis was only 0%. And even this was this Ewing sarcoma. So we sent the patient for radiotherapy, and for the radiotherapy he got a fracture. So we put the nail, and later on this nail get failed out, has come out from the snake. So we put this process in this patient. So he is also more than 7 years of follow-up, and he is having good function and is working on this. So this was a child we did in COVID, 11-year boy having Ewing sarcoma proximal femur. So here we change our strategy, and this is after chemotherapy, and we dissect the whole femur and put in the liquid nitrogen for 20 minutes and resil back. At this time we nailed it. And this is how it's functioning more than 6 years. Now we have noticed that some part of the neck is getting resolved, this head. But he is having some limp, and he is still disease free. So we tried pedicle freezing, where we cut the proximal and distal end and put this liquid nitrogen and re-implant this bone. So look at the function in this patient. This patient is having a METS when he presented, so he died after 3 years of follow-up. So we did we hanging hips, we did this Ewing sarcoma, this is post chemo, and just remove the whole pelvis and leave the pelvis hanging. So childs are walking on this without any disability. So this is the case of another case where we did this P1 and P2 and P3 resection, and just hang this proximal femur into this ilium left behind. And this is how she is walking, and she is going to the school for an absolute normal function in this hip joint. So I must conclude there are too many options for reconstruction in pediatric population, but we believe selective option with reasonable good functional outcome with less complication is the best option you select. And biological option no doubt is a valid option with less problem. We use process very rarely because we can't afford every time to have a mega process and have a change. And to get a pediatric implant where you need to have a magnet and do this limb lengthening every time, we don't have an option in Pakistan. So we use a couple of series of around 40 cases recycled bone with liquid nitrogen with a reasonable good function. And the biggest problem we have the infection in this whole series. But still we have a problem. There is not an end. We are getting this huge masses around this, and the people refer to this all complicated huge masses that doesn't respond to any chemotherapy towards this deployment. So we do, this is all inoperable, and unfortunately we do this hip disc article, external hemipelectomy and 4/4 amputation regularly. So this is routine, unfortunate to this system till we have follow and educate the society. And thanks to Allah Rabbil Izzat for selecting us for this wonderful services. So this is what we are getting. We are providing all free of cost in our institute. And this is a beautiful thing we are getting this every time this child bring something for you with this cards and this. Thank you very much.
Thank you, sir.
So any question?
So we can proceed to the next talk, then we will go for the question answer.
Yes. Yeah, folder दिखाएं.
The next talk is also by Dr. Prdiatric, that is on limb salvage in the soft tissue tumor in the children.
स्क्रीन शेयर करें. So again, limb salvage in soft tissue tumors in children is another aspect. So basically, all pediatrics physicians and surgeons do the children visit to them, and they all see the soft tissue lesions in the limbs and all around the trunk and around the back as well. So basically, it's a job of every doctor. Teaching the children should have a clear-cut guidelines to diagnose these lesions. and before referring even to make a diagnosis before embarking onto the surgery. So there are big list of soft tissue tumors and huge one. You can see most of luckily the children have, most of these are benign. And key is to identify which are the malignant and which are this life-threatening lesions that should not be missed, otherwise they create a big problem with the children. So we have seen most of these cases, this hemangiomas and AV malformation, we are working with our vascular team nowadays, so they have big AV malformation in children as well, so we sometimes do operate with them as well. So key is how to approach the soft tissue tumors. So history and examination is the key. But this is baseline. X-ray, do ultrasound, MRI with contrast to see where the lesion, how big it is. And if you have doubt, always do the biopsy. And biopsy should be done the person who is going to operate on this. And this is not necessary what is the size of the lesion. Whatever the size of lesion, confirm the diagnosis by taking the biopsy and confirm it and then plan. If you find out the benign, simply you can excise. You're going to malignant and depend upon which malignant tumor it is. So you have some tumors responding to the chemotherapy, so go straight away for neoadjuvant chemotherapy and then surgery, then adjuvant chemotherapy. So even with the soft tissue, these lesions are also there. We have seen a couple of cases where we have find out the extraskeletal osteoneving sarcomas, where no bone involvement, but only the soft tissue lesions were there. That biopsy turned out with the malignant osteosarcoma, that is the extraskeletal. So I will show you this. We can classify the soft tissue tumors as the benign, as the intermediate grade, and malignant high grade. So these three, it is mostly this rhabdomyosarcoma, synovial sarcoma, and MPNST. These should be evaluated appropriately and should be sent to the place where they manage in an appropriate way. So I will show you the cases. This is, if you see the child, 5-year boy, this huge mass involving the anterior medial all thigh. And this bone is here, this bone is normal, and we took the biopsy that turned out to be the fibromatosis. And in our series, fibromatosis may be one of the most common reasons of soft tissue tumors in children. So we just confirmed after the biopsy and did the excision. And if you see this is extending till the bone. All neurovascular around the medial side was spared, and this marginal recession was done in this. So fibromatosis is again a problem, either operate, not to operate, but huge swellings. So need to operate when they get painful, and that is progressively increasing. And people are trying some chemotherapies, but we have tried, that doesn't work. Most of the time, there maybe disease get static, but these huge masses doesn't respond well to these chemotherapies even. But they are even trying to use this in benign lesions. This is another tumor. If you see this right from this anterocephalus spine to the knee, and this all biopsy turned out to be lipoblastoma. So we just went inside, dissected out the neurovascular bundle and saved the limb. So this is the patient with, again, fibromatosis involving the lateral, posterior, medial aspect, and all brachial plexus was somehow here, and medial side was adherent. So right from the axilla, we dissected out the axilla artery vein, all brachial plexus freed here. And if you see this right from the bone, this is radial nerve here, and all brachial plexus around here. So everything is spared. If you see this huge mass, nothing is visible other than this mass in the arm. And this is how this child responded. And he was making TikTok and sending me some songs with this video on this. So this is how he's moving the arm. So recently we operated another patient. We did the biopsy. That turned out to be this benign lesion, but the clear diagnosis was not there, and then we planned to do the excision. And if you see, this whole femoral artery was adherent on the medial side. Right from the external iliac artery, as well as inguinal ligament, just below it was adherent on this side. So we just went inside and dissected the whole neurovascular bundle. And this is after the resection, and the whole neurovascular bundle was spared here. So buttock is another place where you will have painful soft tissue lesions, and child can't sit, sometimes having nerve palsies as well. So we prefer to operate when they get painful. And this is how. So this was another case with the neurofibromatosis, 16-year, whole posterior side. This is prone, and right from here till the greater shade notch. And biopsy turned out to the malignant peripheral nerve sheath tumor, whole sciatic nerve was involved. So we see this, the whole sciatic nerve was involved with this, and we resected with this because of progression of the disease. But recently, the same patient present with this another mass and the iliopsoas that extending through the nerve into the spinal cord. So that is not resectable, so we are just watching on this patient. This is another girl with spindle sarcoma on the calf, and someone did the biopsy here. So we did the resection as whole, right from this popliteal fossa till this endoachilles, remove everything, but she now present with this another recurrence. So recently we reoperated her and saved the neovascular bundle in the popliteal fossa. And see, but this is the problem again. She got operated, she lost a follower, she doesn't get any chemoradiotherapy, and she came with another recurrence. But she is walking normally still, and we send this child to the oncologist. So this was the child when she was 6-year-old, diagnosed with embryonal rhabdomyosarcoma, chemotherapy was done, and we did the resection and the radiotherapy and everything. After this all, she came present with this recurrence. And this is second time when she present was after the primary surgery, and we find out she got some bone problem and soft tissue recurrence. So we use the same technique of recycled bone, dissect the whole femur from the proximal femur at the subtrochanter area. We make an osteotomy, leave this distal part intact. Oh, this is X-ray basically. So this is recurrent swelling here, and this is bone was gutting involved. So we did the dissection of the whole femur, take this whole soft tissue from the bone, and then reimplant it. This time we use intramedullary fibula, and then there was a failure one, the second failure is the DHS get fail again, and then there's another failure with the DHS because two things we did, one radiotherapy, one chemotherapy, and the recycled bone. So 3 times the bone get dead, but now we put this, this going in a sign of union nowadays. With BMP we use in this case. So fungating is still, we are seeing fungating sole fibromatosis. See the child, similar one, but huge mass lying in the sole. And see this is all metatarsal, but whole sole is getting occupied with this mass. So we dissected out whole, saved the foot, and this is how this child walking in it. This was the case, this child was 15 years, around 8-year follow-up. So took the biopsy, they turned out to be synovial sarcoma. Now see this synovial sarcoma occupying the sole, but coming through the second and third metatarsal. So we take this with the second and third metatarsal as out and leave this toes intact. Now this child is having chemotherapy, radiotherapy, and is having more than 10 years of follow-up. So he is walking at but small toes. Some of this hairless valgus is happening, but he is still disease-free. So I think this is the last one. So this is the fibromatosis. Some general surgeon has already operated, but he got a recurrence, but this mass is lying in the popliteal fossa. So see the nerve passing through this tumor. So this is common pure nerve. So in fibromatosis, the tumor gets so hard, just like a stone, even you can dissect out the nerve from the tumor. So this nerve was spared, whole neurovascular bundle was spared, and this child is having more than 10 years of follow-up now. So, but this is again a problem. See, huge fungating mass, small child, and he don't want to talk me in the morning when you get the amputation. They are very sensitive, and they need a very careful attention when you have such a debilitating surgery to this child. So conclusion, this percentage of patients with soft tissue sarcomas who are referred to designated sarcoma centers after incomplete resection is around 18 to 53%. And this compromises the patient's life. So this is the key we should work on it. When you diagnose there's a sarcoma, it should be referred out to the centers where they manage these children appropriately. And all these tumors should be discussed in this multidisciplinary team to get the functional and the overall outcome in a good way. Even in extensive disease, you can have extensive approach, you can save the limbs as well. Thank you very much.
इससे इम्तिहान दराज बंद है एक अनाउंसमेंट करनी है तो आप जब तक कंक्लूड करें
I would say to our chairman and co-chairman to conclude this session.
भाई सारे बातों में अंदर आते दरवाजे बंद करें
Spine surgery. Spine surgery in pediatric surgery in our country, it is not so famous and it is not so common. So the people who are doing the second fellowship in the pediatric orthopedic surgery, they must think of introducing this facility also. There are multiple facilities in the countries where the scoliosis they are only done in the children hospitals of the country. Even there the scoliosis services they are not available. So we all should think about spine surgery. I am thankful for the program organizers that they have put something regarding the spine in the bottom. Otherwise, we usually miss that. And so the rest is all is done by the Badalini. He is doing an excellent work in the tumor surgery.
Thank you. It was a wonderful session, and we have wonderful speakers from the Bharat. His Excellency talked on the spine, especially pediatric spine. That's right. Taking care. And also we have wonderful speakers, eminent speaker who are online, Professor Chima from Bahawalpur and Professor Jory from India on CPT and brachial plexus injury, and Dr. Badar has extensive talks on benign and malignant tumors and especially lip surgery. He has extensive experience and he has showed wonderful examples at case 3. And also Dr. Umar Fahin, he had a good lecture on the scoliosis. So thank you for attending this wonderful.
Please faculty to come here. Faculty. Faculty sorry. International and local faculty, please. And the participant up. कुछ नीचे बैठेंगे फोटो निकालना है यार अनाउंसमेंट फोटो की इसके बाद खाना है तो हमारे दोस्त थे तायरनी चौधरी जो खाने पे बुलाते थे पता है क्या कहते थे सर देयर वाज माय फ्रेंड माय टीचर इज देयर so when he called his friend party वो he used to say खाना तैयार है खाने चाहिए means food is ready but go to the police station जगह जी बात this so खाना तैयार है हाँ शिफ्ट तो ये वाला फैकल्टी थोड़ी नीचे आ जाए फैकल्टी और कुछ लोग भी आगे बैठ गए ना जो बैठेंगे वो उतना अच्छा फोटो आएगा तो एक आदेश जितना नजदीक हो गए ना उतना आपका फोटो अच्छा आएगा आ जाए बेटा आप आ जाए आप आगे करिए बहुत सारी आप बैठे थोड़ा सा और नजदीक आ जाए सी बना लेना थोड़ा सा सी yes that's good keep my space में निकल जाओ आगे भी सारे so there is one there okay then थोड़ा सा साइड में फिट हो जाओ हाँ जो there is my camera में पक्का अगर फोटो नहीं आया तो बच्चा तो बेटा है
पार्टिसिपेंट सब लंच में चले जाइए सिर्फ फैकल्टी टू स्टे प्लीज फैकल्टी फोटो लेना ओनली फैकल्टी बाकी लगे भाई ओनली फैकल्टी बाकी
स्टेशन पे होना चाहिए नहीं सर हम लोग ये सर ये फैकल्टी में आ जाओ सर आप फैकल्टी में
United to stay and all faculty go for lunch. Saturdays, yesterday we did. And after lunch there is one session and there is international law in 1 hour room lecture. Baki sab chale, one industry please come for the sheets. Amit United.
सर ये फोटोज को कौन कर रहे हो मुझे भेजने सारे यार
आज मिलते हैं
अच्छा ठीक
है मूंखे ॿुधाए पियो कान्हे रशीद मूंखे उन टाइम ते फ़ोन करे ॿुधाए कोई ॻाल्हि कान्हे यू आर हियर डोंट वरी माइक तो माइक हाँ सर वो तो पहले बाहर वाले हमको ठीक है
Can we call the AGP pharma people to come on the stage to receive their shield? The AGP pharma. Can we have the Gen Nuclear Pharma people to come forward, please, to receive their shield? Gen Nuclear. Can we have the Farm Evo people to come forward, please, to receive the shield?
Yes, all of you. Yes. Thank you.
Can we have the Rich International, please, to receive their shield? Rich International.
Okay, yes, all of you. Yes, Prdiatric. Thank you. Next.
Edco Pharma, come forward, please, to receive your shield.
Edco. वाला है?
Can we have ACCBS, please, to come forward, please? Benchmark Pharma. Benchmark. Do we have anyone from Benchmark?
No.
बेंचमार्क अंदर बताया मुझे नहीं बताया नवीन अंदर एडकोल बेंचमार्क फॉर्म
Can we have Hilton Pharma, please? Hilton Pharma. सर उर्दू में बता दो। हाँ है सर, है इनका है।
ईरानी वाले कहाँ हैं? देखिए, यहाँ देखिएगा। Wait. Thank you. Next.
Hirani Pharma, come forward, please.
Benchmark.
हाँ. Benchmark.
देखिए, सर यहाँ देखिएगा। सर यहाँ देखिएगा। Thank you.
Solace Pharma, please come forward to receive. Solace Pharma.
चलो उसको बुला लेंगे।
Skylight.
Radiant for them.
नहीं अभी होगा।
Grand dinner. Barbecue का हो गया? Okay. Yes.
अभी होगा सर।
Yes. Thank you.
IQ Pharma.
है IQ वाला। IQ का है ना वो आ रहा है। आज ये IQ तो आ रहा है। IQ वाला कहाँ है? आ रहा है सर। मशरूम है। Okay. Yes. Thank you. IQ.
ठीक। Sir, Ovation Healthcare. Ovation Healthcare, please come forward to the stage.
शीट बनवाने में शीट है।
हाँ।
शीट बनवाने में शीट है। आज
कोई बात नहीं। इसको पता लग जाएगा नहीं अच्छा क्या बनाएगी। इधर आ जाइए। आप आ जाइए बेटा। Okay. Yes. Thank you. Yes. Thank you. Next.
Atco Pharma.
ये आपने Atco वाला है।
ये दोस्त नंबर एडको वाला नहीं।
दोस्त नंबर कौन सी ये हमारे दो डॉक्टर्स कौन सी कंपनी?
Atco Solace. Dr. Jamil Ahmed, please come forward to receive your shield and. Sir, we'll present this to the Orbit people as well.
ये थैला मेरा है, ये तेरा है। Okay, yes, याद रखिएगा। Thank you.
Dr. Noman Parikh, please come forward to receive your shield and.
Okay, yes, sir, याद रखिए, sir, आप याद रखिए। Thank you.
Sir, the Orbit group.
डायरी में ले जाऊँ।
Sir, Orbit group.
ऑर्बिट वाला है?
مرصد غير تشغيله.
कौन है ऑर्बिट?
Okay, yes.
Do we have it?
كل أقسام الشغل صراحة. كل certificate طلع.
Sir, there are few PGs from all the way from Quetta, sir. Dr. Dost Mohammed. Sir, PGs from residents from Quetta, sir.
Okay, yes. Thank you. Okay, Yariko. Yes. Thank you.
Video. Dr. Ehsan Durrani.
Sir, Dr. Ehsan Durrani, sir, from DBT, all the way from Quetta. Sir, कितने मिल जाए? इसकी टेंशन क्यों है? तस्वीर होगी ना इसमें क्या? Presenting is Kashif. Dr. Ismail, kindly come forward.
Thank you.
क्या? एक
हो गया ना? कौन रह
यस
गया?
यस सर, ये एटको और इसके तीन
वाला
रह
आई
गए।
नहीं, स्टॉल लगा
सोलेस वाला, सोलेस, एटको और जेन न्यूक्लियर।
बुला लें दोनों पर फोन SMS कर दो उनको।
ये इसके पास रखा
इसमें सर नदी बची बस सकी मैच पास सर शहजाद वाली शुक्र आज
सर आ जाए सर, ये कोयटा कुराशी हो जाओ काशिफ जान। तो आपको अभी फ्री राइड भी चाहिए कोयटा तक?
और कुछ फैसिलिटी आपको चाहिए आज
एटको फार्मा, कहाँ पे रखना है ये जेन न्यूक्लियर का है और सोलेस का।
Listen. Come down. Okay. Pediatric. Newborn food animals. This one. Oh shit. Okay, I'll hold it. Can we check if it's working? Okay. I don't have any video, so it should be okay.
Done?
Yeah.
it's like small plane. Okay, it's here. It's good. It's American stuff. Hour before food. 1 hour before. 1 hour. An hour from now we should be here. An hour from now. So 1.5 hour. 1 hour before the flight. 1.5 hour maybe you have to land. An hour you also opening. Look at that. Just like we put PC. But we will reach there by Monday. Can you connect this up?
इसको नीचे कर देते हैं फ्लिप तो नहीं होगा आप कनेक्ट
Can you connect?
जस्ट अ मिनट
फाद भाई आ गया स्विचर पे आया रुक जाओ
ये वाली आप ही करेंगे
मार्क्स एंड क्लियर का पहला है
ठीक है सर नेक्स्ट डॉक्टर बोले को लेना है
फाद भाई देखें फाद भाई फाद भाई किसी भी नहीं आया
हो गया जगह पे
मिस आप अनाउंसमेंट शुरू करें हमारे रिकॉर्ड पर डालो हमारे रिकॉर्ड
Welcome back everyone. Now we are going to start our next session. For this session I would like to request all chairs to come on the stage. Chairman Dr. Nusrat Rashid, Co-Chairman Brigadier Faraz Urfi, Dr. Parvez Ali and Dr. Salik Kashif. Please come on stage and have a chair.
Yes, sir. Okay. Just one.
For the first lecture, I would like to request Dr. Mark Sinclair to present on classification for clubfoot deformity in walking age group children. Do we have a common language?
I don't know. I'll tell you. Okay. All right. Thank you so much. And sorry for starting the session early, but I need to fly out at 6. So thank you for bearing with me. So the reason for this talk mainly is because, like many of us, we deal with a lot of clubfoot, and I felt that although the Prdiatric classification is used for small kids and it's an excellent classification, it doesn't really relate very well to walking age children. And I think we're kind of missing a bit of
classification that might help us here. So we start off by saying, what are the indicators for a functional foot? The big question is, what is a functional foot? Do we use radiographic images? Do we use the clinical assessment? Is there any specific test or score that we can use? Is a patient-based self-assessment maybe better? Pedobarography, electromyography, gait lab. It is all not quite clear when we talk about a functionally good foot, what that actually means. We do know that clinical assessment has certain expectations. We know that the plantar flexion should be around 45. We have about 15-20 degrees of dorsiflexion and so on. But how does that relate to an actual outcome in clubfoot deformity? Pedobarographic exams are done, and we've published something on this, but it really doesn't give you a sense of if the foot is functional or not. What we want to know is very basically, do we have a good outcome or not? Is this a good foot or not? And with x-rays, it's the same thing, and we've known this for a while, that an x-ray does not really define the function of the foot, and as Ponseti doctors, I might say, we've essentially given up on x-rays to understand the foot anatomy, because it doesn't really matter when it comes to function, pain, and chewability of the foot. What we do know, I think, is that more deformity means more pain. So defining the deformity in the best possible way, I think, is the best way forward, and we need to look at scores that allow us to do that. In terms of function, what is normal dorsiflexion? I mean, in the past, with a normal ankle, we expect 20-30 degrees of dorsiflexion, but when we have a Ponseti foot, very often we're happy with a lot less, right? We'll say, oh, this has 5 degrees of dorsiflexion or 10 degrees, and we're happy with it. There are very few studies, one out of Iowa with Fred Dietz, that said that Ponseti feet that were good had about 7 degrees of dorsiflexion. So that gives us some idea. And Ponseti's book suggests 15 degrees. So we kind of know how much dorsiflexion an ankle needs to perform normal day-to-day functions. This study here is a gait analysis with the Oxford foot model. Also interesting, with 36 patients. And the result also here shows that we have a dorsiflexion of approximately 16 degrees. So this is probably an indication of where we should be. Now, there are sociocultural factors, and I'm sure in Pakistan, very often squatting is part of daily life. In other countries, we tend to sit on chairs most of the time. And I see this in the UAE as well. I mean, the knee function after knee replacement has to be very different, for example, in Middle Eastern countries than in European countries. So also here, I'm not sure that squatting necessarily is a good way to measure foot function alone. Quoting Ponseti, the goal of the treatment is to obtain a functional, pain-free plantigrade foot with good mobility. So these are the criteria I think that we need to look at. Functional, pain-free, plantigrade, and a good mobility. So how do we do this? What do we look at? When we look at the function, we look at activities of daily life. How do the patients perform in sports? In terms of pain-free, we look at, it's obviously a subjective measure, quality of life measure. We have the Oxford foot model, club foot model that we talk about. Plantigrade is an objective measure, of course. Good mobility, what is good mobility? Which is said ankle range of motion from 7 to 15 degrees perhaps. And modified shoes, well, ask the patient what he's wearing. The question remains, what is functional in what country and what group of patients and in what context? So the other thing is parental expectations. Living in Dubai, we have parents that all think their children are superstars in sports, and they want them to become professional athletes. Sometimes what's okay for an average child is not sufficient for especially the parents that want their kids to excel. And not everybody, like this lady, becomes an Olympic champion being born with clubfoot deformity. So this is what we need to consider. X-rays, we know, are poor predictors for outcome in clubfoot. The general drive must be away from objective measures with more patient-based subjective scores. Foot morphology does relate to the presentation of pain, so this is one of the aspects that we can look at. And we need to appreciate individual cultural variations in what we call is functionally adequate. So, what is then the next problem is, how do we define a relapse? If we don't know what's a good foot, how do we know what is a relapse that we need to treat? And the definitions are very, very poor. If you look at the publications, some say, well, any recurrent deformity is a relapse. That's very general. Others say recurrence defined as the need for any subsequent operative treatment is a relapse. So how do we define this? With the scores that we have the DiMeglio score, which is common. It's based on angles and sectors, but it doesn't really talk about dynamics, about motion. The Pirani score is excellent for the newborn, but quite frankly, the medial crease and the posterior crease, which are two of the 6 signs, don't really tell us much about the clubfoot in a 4-year-old. And the Ponseti-Lavec system also uses X-ray, which we know is not really very helpful when we try to identify the function of the foot. There is one publication of Dr. Basker, which I think is very helpful, because he talks about 2 aspects of the foot. One is the ankle movement, and the other is the subtalar movement. Those 2 movements define foot function. And he also talks, which I like a lot, about a dynamic form of relapse and a fixed form of relapse. Because we do know that ultimately, when a relapse starts and we turn into this yellow phase, it's not immediately a fixed deformity. We have dynamic deformity that happens prior to any fixed foot deformity. So the dynamic signs would be the lack of active ankle dorsiflexion or a lack of subtalar abduction. Those are dynamic signs. When the foot supinates during swing phase, these are the things we observe when we look at the child walking. Fixed deformities are rigid. But at the beginning, when we want to identify a relapse, we need to look at those dynamic signs that are, I think, very important and bring the foot into a worse situation. So in 2019, we published a paper on the PBS score. This was done with Stephanie, who works at the Karolinska Hospital, and with some input from Dr. Pirani. And we felt like capturing dynamic and fixed deformity signs would be helpful in evaluating possible relapse. For this, we had standing, walking, and sitting exams, and we looked at the hindfoot and the mid or the subtalar joint separately. So when the child stands, we look at the hindfoot, and we define if the hindfoot is in varus or not. The varus is very much defined by subtalar motion, right? If we don't have subtalar abduction, the heel remains in varus. The second thing in a standing child, we look at the fixed forefoot supination. If the first ray is elevated and the head of the metatarsal doesn't reach the floor, we have a fixed foot deformity, which is mostly also linked to the subtalar movement, so the supination in the subtalar joint. When we look at the child walking, we look at if the child has a dynamic forefoot supination during swing phase, as well as if there's an early heel rise. So those are dynamic signs during walking, which I think are very important to identify a relapse at an early stage. And when the child is sitting, we look at the subtalar abduction, very much what we do with the Pirani classification. But we also look at the active dorsiflexion. How much can the child actively dorsiflex? As well as how much does the ankle passively dorsiflex? So with this, we have dynamic and fixed deformity assessment. We have it in a standing, walking, and sitting position, and we look separately at the ankle joint and the subtalar joint. Now, when we looked at this, and we classify this into different levels from 1 to 4, so we get a score from 7 in a perfect foot to 18 in a very bad foot. And when we looked at the correlation with the Roy score, for example, we can see that the validity testing suggests that this is actually fairly reasonable validation of the score with good correlation with the Roy score, which is a patient-centered questionnaire on foot function. Also, the inter-observer agreement was actually close to perfect with 0.93, so the ICC also suggests that here the PBS score is superior to other scores. Even if you look at this on video, so there is a study that also Salih Kashif was an author of, where a video was taken of the child and 4 pediatric orthopods looked at the video and rated it according to the PBS score. And actually, the inter-observer reliability was good with 0.82, which is also helpful when you want to use video as a tool. Even if you compare the PBS score with Dimeglia and Pirani score, our interclass correlation coefficient concerning inter-observer agreement is actually better than the other tests. So this test is now being used as a regular test for follow-up of clubfoot in the Swedish National Registry, which I think is a good step forward. It is easy to use and also favored by some of the clubfoot organizations worldwide as a preferred method. However, this version of the PBS has a bit of a weird score system in that it goes from 7 to 18, and that we overemphasize the ankle function against the subtalar functions. It's not evenly distributed. So we're currently working on a revised PBS score that hopefully should be out soon. So for foot function in a walking age clubfoot, I would say it has a subjective component we cannot forget, so the cultural context and habits of the individual. The Oxford Clubfoot Questionnaire, I think, is a very reliable tool and an excellent patient-reported measure for clubfoot in the follow-up situation. Deformity reduces function. We need to identify the deformity because as physicians, we obviously don't want to just know how the patient's doing, but what is not good in the foot. And for that, we need a proper clinical evaluation tool. The PBS, at least at the moment, shows the best ICC. So to me, this is the best tool at the moment to assess a clubfoot and to assess if treatment is necessary. And a further development of the revised PBS score is on the way, and hopefully will be able to help you in your practices. This has been my last talk. I would like to thank the organizers for inviting me again. It's now, I think, the 8th year, so thank you very much for bearing with me. This morning I had the pleasure of seeing the Indus Hospital. Thank you, Aisha. Thank you, Dr. Amin, for taking me in. It's been a pleasure. And as always, thanks to everybody. If there are any questions, I'd like to take them because I need to leave, unfortunately. I mean, what is this? What you got?
Thank you very much for very enlightening talk. I was not aware of this score and learned a lot about it. Just wondering, is the revised or the original be published so that we can then start using it?
Soon, hopefully. So there's a reason why I'm going to Peshawar. It's exactly because we're going to look at this. We're going to do an inter-observer reliability study on the new version. The new version will be more linked to the Pirani score. So it'll also be from 0 to 6. So it's easy, if you know Pirani, to use a revised PBS score. And it'll solve the problem that we overemphasize the ankle function versus the subtalar function. It'll be half-half. Because I think at the end of the day, any relapse, those are the two, say, functional elements that define a relapse, right? It's a lack of ankle dorsiflexion or a lack of subtalar abduction. We've learned this from Ponseti, and I think those are the two elements that need to be looked at from a dynamic and from a fixed deformity point of view. Yes. Hopefully. I'm open to it, of course.
Okay, thank you very much, Dr. Mark. I think we should have a big hand with Dr. Mark because he is not to lead the School of Pediatric Orthopedic Society is a whole lot because he has been regularly traveling to Pakistan. Even if the situation, political situation or other situations are, last time there was a lot of floods and hills in Dubai and he made it to Peshawar.
Yes, I even remember when we were in the mountains that a snowfall.
Yeah, avalanche. So Professor Gulayan Mas, we talk about early assessment of neonatal deformities, how to avoid misdiagnosis and overtreatment.
Okay, good afternoon everyone. So
when this topic was given, I was, searching for what can I talk about. So when we say neonatal foot deformities, so most of our practice is busy on clubfoot. So there will be a small talk about clubfoot and congenital vertical talus. And I'll also mention a couple of differential diagnoses in tibial bowing. So if you look at the clubfoot deformity, this is a very common and popular saying of Dr. Ponseti. Failures are more often due to errors in technique than to the severity of the deformity. So Ponseti technique is very important and very it needs to be known very well by every pediatric orthopedic patient, orthopedic surgeon. So one of the first thing I will mention about is the mistake we made in diagnosis. As we know, there are two types of clubfoot. One of them is the positional clubfoot. This is a mild condition where the baby's foot is twisted due to the confined space in the uterus, and the other one is the congenital and the structural one. So this is the kind of real clubfoot that we are dealing with. And I think the most easy way to differentiate between two of them is the physical examination. So we have to examine the patient's baby's foot, and the most important thing we look is the mobility of the foot, especially the hind foot, tendon structure and tightness in the tendon Achilles. If the foot is flexible, if there is no echinus deformity in the hind foot, and if we can correct the forefoot easily without significant manipulation, this is probably a positional clubfoot, and most of the time simple physical examination, physical therapy, stretching exercises are usually enough for those foot. The other thing we need to be careful about and we need to diagnose is the complex atypical clubfoot. So we had a small discussion about that in the morning, so maybe we can keep on talking about that. So it's kind of a severe form of clubfoot, and if you look at the incidence of complex atypical clubfoot, it's somewhere between 10% and 20%. So those feet are short, stiff, and puffy. They usually have a deep plantar crease, an posterior ankle crease, and most of the time again the first toe is hyperdorsiflexed. So why do we have those atypical clubfoots? Very rarely they are congenital and idiopathic without prior treatment, and they are not sometimes associated with any kind of syndromes. And a good Ponseti technique is usually successful. Most of the time there is no need for modification in those feet. But we may have to spend more time with the first cast in those patients to correct the cause deformity. The other reason, and in my practice, I think this is the most common reason I see during my clinical examinations, and I see from the history of patients, is it can be iatrogenic after inappropriate Ponseti casting. And the most common mistake I observe is the correction of the forefoot pronation and not correcting properly the first foot pronation and chaos deformity. So if you force the foot into abduction before you correct your chaos deformity, you get a worse deformity than before. So these are the three patients that I saw in the last maybe 2 months. This was 3 months old. This is after 6 casting. So he still has deep plantar crease and a deep skin crease in the posterior part of the ankle. And this one is at 3.5 months old. This is after 10 casts. So why 10 casts in 3 months? Because every cast the doctor puts on
was slipping down, and the patient and the family was coming to clinic again with the cast in their hands. So they applied 10 casts, and this is the shape of the foot. They even do the tendinochilus stenotomy here, but if your casting technique is inappropriate, it wouldn't help. And this is after 5 casting. So what needs to be done on those patients? So there is, if you look at the literature, there is a modified casting technique where the knees are bent to around 1 and 110 degrees, and there is a modification of the forefoot manipulation, where we manipulate all the metatarsal heads together if there is significant chaos in all the toes. So what I'm trying to tell is, in those patients, you may have to do some modifications with your casting technique. And the thing we were talking about in the morning, doing the tendinochilus stenotomy right at the beginning sometimes helps on those patients. The other reason for complex atypical clubfoot is it may be secondary to underlying disease, and we shouldn't miss that. This is one of my patients, and you see when you examine the knees, you get severe limited knee flexion. This is extension contracture in the patient, and this patient has arthrogryposis. So arthrogryposis, spinal dystrophism, and sometimes peroneal nerve palsy causes this kind of deformities, which doesn't look like a regular clubfoot deformities. You see there is a deep crease, all the toes are bent together, and there is significant varus and adductus. So we need to identify those patients with arthrogryposis and arthrogryposis-related clubfoot. We shouldn't miss that. They are usually more stiff and severe deformities. There's a high risk for recurrence, and those patients may have many additional abnormalities. And this is one example to that. And this was the example I gave in the morning session. So I did a three Ponseti casting, 3 first casts in this patient, and this is after 3rd cast. So there is no movement in the heel, and it's still in varus. So that's the kind of patient that I do tendinochilus stenotomy right at the beginning. And this is intraoperatively. I did a tendinochilus stenotomy, and I also tried to bend the knees. So weekly Ponseti casting after tenotomy, and this is before 2nd casting. And this is after 3rd casting. So sometimes you may have to do a 2nd tenotomy after those manipulations and casting. And that's another patient. This is 5 months old, a little bit older, and had some casting elsewhere, and they all slipped off. And if you look at the knee, there is extension contracture. And I started again on those patients, in this patient with tendinochilus stenotomy at the first session. I did a rectus stenotomy and get some knee flexion, and this is before 3rd cast. Okay. So in my practice, if it is a complex atypical clubfoot, I sometimes change the casting technique and get the tendinochilus stenotomy procedure a little bit, do it earlier. The other thing we should avoid is, maybe we can call it over-treatment, aggressive open releases and osteotomies in previously operated clubfoot, especially if the patient has arthrogryposis. This is one of my patients. So this was a recurrence of deformity, and we did osteotomies and arthrodesis, and this is what I got after surgeries. I think if the foot has been operated before, we should, our treatment program should include as minimal procedure as possible. And in those patients, I think we should keep in mind the external fixator. So here, we couldn't do free flap because there was no artery to make a good anastomosis. The plastic surgeons couldn't do a rotational flap, so we treated this patient with cross leg flap. So this was a 30-year-old woman with a cross leg fixation. So it was a hard time for everyone. yeah, the external fixation, an external fixator method should be kept in mind. The other misdiagnosis in clubfoot is most of the time we can mix and misdiagnose the ankle dorsiflexion and forefoot midfoot break. So why does it happen? It's usually if you try to dorsiflex the ankle before correction of cavus and adductus and heel varus. So before your heel is corrected, if you try to dorsiflex it, your subtalar joint is locked and you get your dorsiflexion from the midfoot. And you get a wrong sense of having dorsiflexion, but actually this is dorsiflexion from the midfoot. And in those patients, I think X-ray is a good idea, and I sometimes use that. Is this range of motion coming from ankle or the midfoot? So there is a nice study published in GBGS American in 2015 from China. So if you get a lateral X-ray in a hyperdorsiflexed, with a hyperdorsiflexed position, and if you look at the relationship between tibia and the calcaneus, you can estimate the length of the tendon Achilles. And if this anterior tibiocalcaneal angle is less than 80 degrees, basically it shows that your tendon Achilles length is quite normal. And if you look at the clubfoot literature and our experience, what is over-treatment? I think complete subtalar releases are kind of over-treatment. So we have all seen patients who had bad results with complete subtalar release. We should avoid from this procedure as much as possible. The other problem we see in the newborn period is congenital vertical talus. It's a rigid pes planus deformity, as we know. The hindfoot is in flexion, midfoot is in dorsiflexion, and forefoot is in abduction. And there is usually a significant skin fold, and the foot looks like we call it rocker bottom foot. So etiology is 50% idiopathic and 50% neurologic, and associated to some syndromes like and neurologic problems like spina bifida and arthrogryposis. What usually is mixed, I guess it's oblique talus. Not every week, but maybe 2 patients in a month, I usually get a referral, oh doctor, this patient has a congenital vertical talus. Because if they look at the X-ray, it looks like a vertical talus, but if you examine those patients with oblique talus and pes planovalgus, they all have very soft and flexible foot, and I think this is the most important part in distinguishing these two deformities. If you look at the X-ray, this is an X-ray of a congenital vertical talus. There is dorsal subluxation of the navicula and calcaneal and cuboid. There is calcaneal flexion. The talocalcaneal angle is increased, and the tamba angle, lateral talar axis, first metatarsal angle, basis angle is also increased. But if you're in a baby's foot, I think it's kind of an over-treatment, and we should be aware of this minimal invasive method. I think there's a talk about that. This is Dobbs method. It's kind of reverse Ponseti method. And casting and doing minimal invasive surgeries on those patients are much helpful. This is also one problem we see in a newborn very often, valgus. So this is basically a deformity in the distal tibia. And how can we differentiate it? I think if you close the tibial part, this foot looks pretty normal. And this is kind of how we can, differentiate between these two deformities. So there is spontaneous resolution in this deformity, but usually there is, at the end of the growth period, there is usually 4 to 6 centimeters of shortening. And the literature says that this is something, spontaneously corrects. But this is one of my patients. He was 6 years old. So this is another study from 2018. So some of the patients does not get the expected correction. So we should be aware of those patients and tell the families that, okay, most of them Emilia, and the other one is a congenital tibial pseudoarthrosis, so we can see it in newborn period. And Tibial hemimelies, if there is any problem on the first ray, tibial hemimelia should always be kept in mind. And there are some simple congenital anomalies that we rarely do surgery. So this is curly toe and this is overriding toe. In the last 15 years, I guess, I just did one curly toe surgery. So they are usually and most of the time resolves by itself, and no aggressive treatment usually is needed on those congenital deformities. Okay, thank you.
Thank you, sir. Such a nice talk. Any question, please, to Professor Gani Dharmasara regarding.
Okay. Thank you.
Thank you, sir.
Oblique talus. I think there is a question. Okay.
Hello. It was a very nice presentation. I have a question regarding the oblique talus. So, what do you do for the oblique talus?
So it's a differential diagnosis between congenital vertical talus and oblique talus. So congenital vertical talus is always stiff. So tendon Achilles is always short, and if you look at the hind foot, there is significant calcaneal flexion, which you cannot correct by simple manipulation. But in oblique talus, most of the time, those patients are very flexible, and if you examine the foot, you can correct the talonavicular relationship. And if you want, you can show it with a lateral X-ray. You make a plantar flexion maneuver in the feet, and you get a lateral X-ray, and you'll see that talonavicular joint is reduced and well aligned. So this is how you can differentiate it.
Differentiation is easy, but the thing is if we left that patient without any treatment.
Okay, so you're asking about the treatment?
Yeah.
Okay. I don't usually treat them. They are really flexible feet. I just, if there is some contracture in the tendon Achilles, I give some stretching exercises and I just follow those patients. Until he has any problems with shoe wearing and etc.
But later in life, they walk on the medial side. The later what is the pages.
So natural history of basically those patients have flexible flat foot. And if you look at the natural history of flat foot, so most of them get some correction during their childhood. So I think it's wise to wait a little bit and just observe the patient. You can give some stretching exercises, but if your question is, are you giving some shoe lifts and special things inside the shoe, I don't usually prescribe shoe lifts.
Okay, thank you.
Mm-hmm.
Okay, thank you, sir. Next talk, I would like to invite Professor Karimul Sahab. The topic is comprehensive colorful establishing sustainable system from newborn detection to long-term direction.
शो करें फ्रॉम फर्स्ट स्लाइड
पीडीएफ है ये
इसका नोट
पीडीएफ है सही है
I'm sorry for the delay. थोड़ी प्रॉब्लम है इसमें सॉर्ट ऑफ Bismillah ar-Rahman ar-Rahim. Just we all are feeling post-prandial, so I think my system is also feeling like that. At the end of our this, we are almost at the end of our this conference. So I think most of the discussion has been done about my topic. So it will be almost a review or summary of all the discussion that has been done about the clubfoot, and I will try to make it as much short as possible. So some statistics about the clubfoot data. Approximately 2 lakhs children are born with clubfoot each year worldwide. The vast majority, or 80%, are born in low and middle income countries. Without treatment, clubfoot leads to a lifetime of disability, pain, and social stigma, trapping families in a cycle of poverty. It is a harsh truth that in 2023, only about 20% of the affected children in the low and middle income countries receive treatment. So this hard spot shows the low and middle income countries where most of the cases are reported. So our objective is to establish sustainable national clubfoot programs that make the POSPCON method accessible to every child. And our vision is a world where a clubfoot diagnosis is not a lifetime sentence of disability, but a treatable condition with an excellent outcome. The key concept is that we must move from isolated short-term principle to an integrated government-supported national-wide system. We had a workshop on the clubfoot in Quetta in this conference, and we had there elaborated talks and hand-on workshop at the at the end of the course. So there is just a brief review about the POSPCON technique. A clubfoot is not a simple foot band. It's a complex multiplanar deformity, and it is remembered by the acronym CAVE. So C is for midfoot cavus, A is for forefoot adduction, and V is for hindfoot varus, and E is for ankle equinus. The POSPCON method was developed by Dr. Ponseti. This method is now the universally accepted first-line treatment. It is effective, safe, and significantly reduces the need for extensive surgery. The method is cost-effective and can be taught to a wide range of healthcare providers, making it ideal for middle and low-income countries. So in the first phase, early detection can be done on the prenatal ultrasound at about 20 weeks of gestation. If clubfoot is suspected, referral for the prenatal counseling with the clubfoot practitioner to prepare and reassure the parents. Postnatally, the diagnosis is clinical at birth. Newborns must be referred immediately, preferably within 48 hours, to a specialized clubfoot center. And the goal is begin casting between the 2nd and 6 weeks of age. So in the second phase, manipulation and casting is done by gentle stretching and manipulation of the foot using the thumb as a fulcrum on the head of the talus. A well-modeled above knee plaster of Paris cast is applied to hold the foot in correction. Casts are changed weekly for approximately 5 to 8 weeks. The calcaneum must not be touched during the manipulation, as its position corrects naturally. This is a key principle in the POSPCON technique. So in the first step, supinate the forefoot by elevating the first metatarsal. In the second step, correct adductus and varus, abduct the foot under the fixed talus. This automatically corrects the heel varus through kinematic coupling. Peroneal scoring is a simple, reliable clinical tool to assess severity and progress. Use it at every visit. The foot is ready for tenotomy when the lateral head of the talus is covered, that is the peroneal scoring is 0. The foot can be abducted 60 to 70 degree. The heel is in neutral to valgus. So the third phase, that is the final step to full correction. After the cavus, adductus and varus are corrected, the equinus almost always remains, and tenotomy is needed in 85 to 95% of cases. The procedure is simple. Percutaneous release of the Achilles tendon is done. It is performed in the clinical setting under local anesthesia for infants under 8 months of age. In older children, we may need general anesthesia in the OT setup. A final cast is applied for 3 weeks with the foot in maximum dorsiflexions and 60 to 70 degrees of abduction. The deformity has a high tendency to relapse. Bracing is not optional, it is essential. Boots are attached to a Dennis Brown bar at shoulder width. The bracing regime is full-time, that is 23 hours a day for the first 3 months after tenotomy, and then part-time until the age of 4 to 5 years. The greatest predictor of success is compliance, and parents' empowerment is equal to positive outcome. The success of the entire treatment rests on the parent adherence to the bracing protocol. So the barriers to compliance are lack of understanding, social stigma and family pressures, practical difficulties like skin issues and hot climates. So our role is, we must move from being prescribers to partners and educators. There is a quotation of a father in Bangladesh. Now I feel that I have been able to heal my princess by ignoring all the social, religious obstacles. As a result, today I can say that I am the father of a real princess. So from pilot projects to nationwide programs, the 4 interlocking pillars are: number 1, government integration; number 2, workforce training and mentorship; number 3, supply chains management; and number 4 is data collection and then monitoring. There is a case study from Uganda, it is one of the oldest and the most successful program in low-income country. The key success factors are that effective use of existing workforce, trained orthopedic officers that are mostly non-physicians to deliver care, ensuring wide reach. Government partnership is by long-standing commitment from the Ministry of Health, and public supply chains integrated the procurement of plaster of Paris and braces into the national system. So the takeaway message is, we don't treat feet, we treat children. Progress is there, but it is not enough. There is data in 2023 from 30 low and middle income countries that 83% of cases are recorded in these countries. More than 40,000 new children were enrolled in the treatment program. However, only 67% of children received their first brace. So the challenge is there is a lingering effect of COVID-19 disrupting the services and led to older children starting in the treatment. Surgery is the exception, not the rule. While the POSPCON method is the gold standard, we must not abandon surgical training entirely. The indication for surgery are atypical or syndromic feet not responding to POSPCON, neglected untreated cases, residual deformities, relapse, not manageable to recasting. So our responsibility is, yes, I'm about to finish, to ensure that the next generation of surgeon is trained to perform the right surgery at the right time for the right patient. Recommendation for long-term impact strategy are: the government must allocate domestic resources for clubfoot care as part of universal health coverage, fund and support training of the trainees program to create self-sufficient local experts, create clear, simple pathways from birth centers to clubfoot clinics, implement simple break to track long-term outcomes, and drive quality improvements. So at conclusion, we have the knowledge. Now we need the will. The facts are clear. The POSPCON method is a proven, cost-effective solution. Sustainable systems are possible. So it is our collective goal to ensure that by 2030, no child is denied the right to walk and run because of a lack of resources to comprehensive clubfoot care. Thank you. Is there any question?
Now, our next talk is tuberculosis of the hip joint. Tuberculosis after the hip joint. I would like to invite Professor Nasrat Rashid to talk.
Bismillahirrahmanirrahim. Thanks organizing committee for inviting me. So this is quite rousy after lunch to listen the lectures, but it is your patience. So there's a slight change in the topic. So we have jumped from the clubfoot to the tuberculous arthritis, and I wish I can complete this lecture within time. So tuberculosis is very common in Southeast Asian countries, including Pakistan, India, Bangladesh. But unfortunately, after partition, both the big countries in this territory, Pakistan and India, have acquired nuclear weapons, but they are not still capable of getting rid of this infection. So tuberculosis is endemic in this area, and this is a very relevant and serious topic because we see a huge number of cases in our clinics in this part of world as compared to the Europe and America, in where the tuberculosis is rarely seen or maybe seen in those patients who are HIV positive or immunocompromised. So, tuberculosis arthritis. Yes. Change the slide changer. Okay. So this is the place where I work. This is Dow International Medical College. This is a part of OJA campus, Dow University of Health Sciences. And this is a part of medical city. This is located in the peripheral skirt of Karachi. And there is a little story that I would tell you, which is very related to my topic. So before partition in 1920, it was basically a TB sanatorium where this campus is located. And the people who developed tuberculosis were thrown out of city for the purpose of quarantine in this sanatorium. And after partition, even it was working as a tuberculosis sanatorium, TB sanatorium, and later in 2008, it was taken by the Sindh government and a medical city with the name of OJA campus. OJA was a woman, a Hindu woman, who was the first lady who was kept in this sanatorium. And this medical campus is named after this patient, that is OJA. So coming back to the topic, my topic is tuberculosis of the hip, challenges and dilemma. Next to spine, hip joint is the most common site of involvement by the tuberculosis, especially in the first 3 decades of the life, like other osteoarticular diseases. Overall, it constitutes 15% of the osteoarticular tuberculosis. Infection of the hip is secondary to some primary focus, maybe in the lungs, mediastinum, in the ileocecal region, or anywhere in the bloodstream. It can secondarily infect the bone and joints. Initial focus may start in the acetabular roof, in the epiphysis, metaphysis, or in the greater trochanter. And very rarely, it can involve the synovium, and it remains there as a synovitis for months. So we all know the clinical features of tuberculosis. This is just a quick review. The patient presents with the pain that is insidious in onset, with the swelling in the hip, limping, pain which is maximum at the end of the day. Child may wake up in the night, and this is especially the night cry, which makes the patient awake from the sleep. Along with the constitutional symptom, because of the poverty and the lower socioeconomic status, the people have a very low cachexia look with the loss of appetite, loss of weight, and the fever. Sometimes limp is the earliest symptom to present with. So we have categorized the stages of tuberculous hip into 4 parts. The first is the synovitis, second is the early arthritis, third is the advanced arthritis, and the later one is advanced arthritis with the sequel. So in stage 1, synovitis with diffusion into the cavity, hip assumes a position of ease, that is the fiber, flexion, abduction, and external rotation with the pelvic tilt with increased lumbar lordosis. Other local signs like the warmth, tenderness, muscular spasm, and the painful limitation of movement may be there. So this is the point where we mostly get misled by the presentation, because it closely mimics the traumatic synovitis, rheumatoid arthritis, because in the children it is monoarticular, and the Perthes disease, the discussion which is being started from the morning from the Perthes. So what we get, the patient in the early stage of synovitis, we may get confused with the Perthes. So it's your clinical acumen to differentiate between the two on the basis of history, examination, and then to confirm it on the investigation. Second stage is the early arthritis. If the disease is untreated and the patient is bedridden, destructive process is spread to the articular surface, and limb assume again the position of feather with the true shortening, not more than 1 centimeter, and there is a marked wasting. Sometimes there is a closed abscess, the cold abscess formation occur, and if this occur, we have to go for the drainage. X-ray may show localized osteoporosis, decrease in the joint space. In the early phase, there may be increase in the joint space due to the effusion. Although in the first stages of the synovitis, X-ray is unremarkable except the finding of an increased joint space. But in the later stages, yes, you can get the radiological findings like the osteoporosis, the decrease in joint space, joint destruction, etc. In stage 3, there's an exaggeration of stage 2. There's a gross destruction of the articular cartilage and the femoral head and acetabulum. So radiological features vary according to the stage of arthritis. In stage 1, we hardly get any finding except the widening of the space. In the stage 2, there is erosion of the articular surface and narrowing of the joint space, and stage 3 is the destruction of the head of femur, as I have said. This is the pictorial presentation. As you can see, actually you can get variable presentation. Sometimes you can, as I have said in the earlier phase, it's normal, but in the later stages you can get a traveling acetabulum picture. There can be a dislocating hip. There can be a stage 4, which very closely mimics to Perthes disease. It can go up to the protrusion acetabuli. There can be atrophic type, and the last type 7, which is a mortar and pestle type. So this is a famous triad of hemisphere, which we usually ask the residents in exam. These are the 3 typical findings of tuberculous hip, on the basis of which we can differentiate it clearly from the Perthes disease, because it has a juxta-articular osteoporosis along with peripherally located osseous erosions along with the gradual narrowing of the joint space. So this is known as a triad of hemisphere, and this is the point of differentiation from the Perthes. So the challenges and dilemma. What is dilemma actually? The dilemma not only comes in diagnosis but with the treatment and rehabilitation as well. So diagnosing TB in very early stage is very difficult, because the clinical signs and symptoms resemble very close with the other diseases, as I have said earlier, with the pyogenic arthritis, with the transient synovitis, and with the Perthes disease. So high index of suspicion is necessary, especially in the context of persistent monoarthritis in susceptible individual, like in the immunocompromised children, in the malnourished, or in with the very poor nutritional status. In immunocompromised patient, the elderly, those who are with the corticosteroid or immunosuppressive drugs. Microbiological or histological test TB still remains the gold standard for the diagnosis of tuberculosis. So here I have a picture of an old patient of mine showing a radiograph with the traveling or the wandering acetabulum. This is another boy, 2-year-old, with the Perthes type of osteoarticular erosion of the joint. This is a sequel of a tuberculous arthritis with the coxa magna. This is another radiograph with the famous type 7 mortar and pestle type of lesion. So if for the residents, it closely resembles with the घरों में हम use करते हैं मसाला पीसने के लिए. So it's a sort of, for grinding the spices. So this becomes, acetabulum becomes narrower, and the femoral head after the erosion becomes like the mortar and pestle type. So this is type 7, and this is a sequel of Perthes, tuberculous arthritis. So again, we have discussed the differentials. Now comes the diagnosis. Histopathology, microbiology, gene expert, and the quantiferon TB are the still gold standard for the diagnosis. When comes the management, we should treat the tuberculous arthritis with a holistic approach under a multidisciplinary team. Not only the medicines, but we should treat the nutritional status of the patient, and there comes the general treatment, medicines, the local therapy, and we must not forget the role of surgery. The moment we have to intervene surgically, we should, and we should not wait till the destruction appears so much so that it becomes the point where we miss the boat. So again, the aim of management is to get a painless, stable, mobile hip without any deformity, limb or limb length discrepancy. So the treatment as the regime guided by the WHO, ATT with the 4 drugs, intensive phase for first 3 months, followed by 3 drugs for the next 3 months, and followed by 2 drugs for the next 18 months. The total time duration for the musculoskeletal tuberculosis is to 18 months, but it can exceed up to 24 depending upon the disease and the symptoms of the patient. Along with that, analgesic and muscle relaxant and the treatment associated with the problem. So mechanical support, we have to give the splints and plaster in order to avoid the contractures. We have to give traction to relieve spasm, to correct the deformity for the joint surface apart. Physiotherapy has a good role. So now comes the dilemma, and the dilemma comes with the compliance. So the key of the good treatment is the compliance by the patient. But unfortunately, we mostly patient they get lama when they get relief from the pain, they leave the treatment, and then comes a problem of multiple drug resistance. So the medical management protocol is the perioperative ATT coverage. So there is a strong consensus on starting ATT preoperatively, typically 2 to 6 weeks prior, to reduce the risk of reactivation. So we will discuss in detail in the next slides that initially it was thought that if a patient is a tuberculous hip, we should wait for the years till the TB subsides, and then we should go for the hip arthroplasty. On the other hand, on contrary to this belief, the research papers nowadays clearly shows that we should go for the early hip arthroplasty. We should start ATT maybe 3 to 4 weeks prior to surgery. We should go for early THA, and that shows promising results. We will discuss it in detail in the next slides. Now we will discuss the problem or the dilemma of the multiple drug resistance. With the rise of multiple drug resistance, TB, the use of WHO recommended short all oral regimes nowadays very famous is BPA-LM, that is a badaquilin, pretomid, linezolid along with the moxifloxacin, is emerging in musculoskeletal tuberculosis in the resistant cases. If the patient is not responding, for example, we have started the ATT, we should not leave the patient, we should keep the patient in follow-up. If patient is not responding, we should go for the diagnosis of multiple drug resistance, and if it came out to be positive, we should change the regime. And this is the current protocol guided by the WHO. So the treatment of tuberculosis surgically depends which stage you are dealing the patient with. If the patient is in synovitis and early arthritis, traction is to be given to correct the deformity. If there is any palpable abscess, you should aspirate or you should treat, you should drain the pus, and there are the local and the international papers who are in advocacy of instilling streptomycin locally in the tuberculous spine or the tuberculous hip. That gives good results. After 4 to 6 months Active assisted movement should be started as soon as the pain subsides, and after 4 to 6 months, ambulation on suitable caliper or crutches can be started. In case of advanced arthritis, when there's a fibrous ankylosis occurs, initial traction regime helps to overcome the deformity, and you may return the patient any usual range of motion. The ideal position in neutral between the abduction and adduction, if you are going for the ankylosis, 5 to 10 degrees of external rotation and flexion between 10 degrees in children, up to 30 degrees in the adults. Again, you have to see the response of treatment. You have to do the 4 to 6 months of conservative treatment. If there's a favorable response, you should keep the patient non-weight bearing for 6 months with support of partial weight bearing for 6 months and then full weight bearing. Now comes the role of surgery. Surgery can be synovectomy, simply. It can be a debridement, arthrodesis or arthroplasty depending on the situation or the stage of disease. So arthrodesis is although not a good option, but in the circumstances which are unavoidable, you can go for intra-articular or extra-articular arthrodesis. There's a option of excision arthroplasty or the girdle stone, which is again not a very good option, but in the compromise situation, you can go for the girdle stone. But in the children, you have to be aware of the fact that you should go after the completion of growth potential. It provides painless mobile joint and control of infection with the correction of deformity. However, there's a shortening of 3.5 to 5 centimeter. With the long-term follow-up, improvement in the bone texture and remodeling and the false joint formation occurs. Now comes the favorite topic, the favorite procedure of nowadays is the joint replacement. The old school of thought was after maintaining 5 years of healed status and after replacement 5 months of ATT, now still a reactivation was there in 1/3 of the patient, still keeping the safe approach of keeping the patient infection free. It was seen that after that precautions, there was a recurrence rate in 1/3 of the patient. Nowadays, the research articles are in advocacy of total hip arthroplasty in a tuberculous hip in the early stages. There's a paper published in the Chinese journal. The conclusion is THA is an effective and safe option for the hip tuberculosis. The essentials for good outcome include early diagnosis, regular perioperative and anti-tubercular chemotherapy, radical debridement of inflamed tissue, and necrotic bone, staged operation if necessary. So here there are two varieties of cases. Ones are those who are with active infection, with the sinuses, with the pus. In those patients, we can go for the 2-stage procedure. In the first stage, we have to do the thorough debridement, the excision of the necrotic tissues, with the pre-operative ATT 3 weeks and continuation of ATT post-op, followed by the THA later on. Okay, I'm going to finish it. So another paper in which again there is a total hip arthroplasty in active and advanced tuberculous arthritis. This is a systematic review of the current evidence. And the conclusion is THA is a safe and effective surgical intervention in patients with active and advanced TB arthritis of the hip. It is recommended that surgery be performed under cover of multi-drug ATT regime in patients with the active sinus tract, abscess and all the necrotic tissues. Surgery may be accomplished in a multi-staged manner. Thank you. So these are some pictures of mine in fellowship. So one of my picture is with Professor Gone. So I'm very thankful to you, sir. Thank you. One of picture is mine with Professor Jose Morconde. Another with in Egypt with the arthroscopy fellowship, and the last one is with Professor Gone. Thank you. Thank you.
After this lecture,
किस नाम से?
वर्टिकल मेरे नाम से हो गया, मोहम्मद अमीन चन्नई के नाम से।
अमीन चन्नई दिखाएं मुझे।
जब तक ये है, can I ask a question? Okay, Karim. इसमें नहीं है, इसमें नहीं है, मतलब नहीं है ना, दूसरे जाओ, इससे ऊपर जाओ, ये सेक्शन 6 में क्या है? नहीं, ये भी नहीं है, इनको पूछो कहाँ डाल रहे हैं हम? करीम आवाज नहीं आ रही, ऊपर रखते हैं।
Regime for the ATT is different in the pulmonary cause and in the musculoskeletal
बस शुरू लगाया तो क्या करूँ?
process. So in musculoskeletal TB, the duration of ATT is still more than 12 months and it can extend up to 24 months. So depending on the disease severity, strain of the mycobacterium, you can change it and you can, tailor it according to the disease. But it is still there at least 12 months of ATT should be given in the monoarticle and the tuberculous arthritis. So musculoskeletal.
I suspect this is the part of Pakistan where tuberculosis is very common.
Yes.
I have followed the same with them. 2 months of this initial phase and 4 months of the maintenance. And we have excellent results. The patient that did not respond the problem was with the drug compliance. And in few cases there was about 6 drug resistance. So the patient that was not responding, we referred this patient to the specialized center where the treatment that are for the drug resistance are being used.
Definitely. In our campus, we have a different separate sanatorium for the tuberculosis, and there is a MDR program there. So in the resistant cases, we refer patient to them. So one point that I want to raise is there's a problem of compliance in our patient. When we say the patient to continue ATT for 18 months, they usually stop it by 6 to 9 months. If we will start in the start, we will say that only continue for 6 months, they will stop the ATT in 3 months. So, there is a problem of communication with the patient and the regular follow-ups. So,
ये जो problem है, this problem is basically stimulated by pulmonary tuberculosis. When you send them to NT treatment to get from there, because this is not available in the market, it is only available on the government free services. So when patients go there, they say they only change it in their need. So then I ask them and we write them to them. This is 18 months and they continue for this G for 18, then they continue the treatment. Then you only please 10 minutes.
Sir, this was my point because we are facing this problem daily. Because the pulmonologists, they follow the WHO guidelines which says that extra pulmonary tuberculosis should be treated only for 6 months. And that is where we all are in a dilemma. If you look at the orthopedic literature, there is duration is anywhere between 18 months to 24 months. But if you look at what the WHO guidelines are and what the ID specialists and what the pulmonologists are doing, they are stopping it. And we face this problem because they go to the government setup, because these drugs are now only available in the government setups. So they have to go there and take them. You cannot buy them from the market, even if it's a prescription. So that's a huge problem. And that's
I always give them a prescription and write them, please continue for this for 18, this month, then they oblige. Thank you, sir. Go ahead.
Thank you very much, sir. Okay, Bismillahir Rahmanir Rahim. 9 minutes and 24 seconds.
Thank you, sir.
I will stop. Okay, this is the Indus Hospital. You're all aware of it. Mark Sinclair was there this morning as well. I'm going to talk about congenital vertical talus or the Rockham water for deformity. This is myself. So, okay. So 1 in 10,000 births is the incidence that is commonly quoted in the literature, and half of these patients cases are bilateral. The differentiation has to be between idiopathic versus syndromic. The pathology is basically the dorsal dislocation of the navicular bone in the talonavicular joint, so much so that sometimes it locks in the neck of the talus, giving rise to what we see there with a rocker bottom foot deformity. So there is forefoot adduction, there is midfoot dorsiflexion, and a hindfoot is in equinovalgus. Various classification systems have been put forward, but these are the underlying conditions, so such as neuromuscular meningomyelocele, congenital contractures such as in arthrogryposis multiplex congenita. Some of them can be syndromal, associated with various chromosomal abnormalities. The problem is in the subtalar complex, which is rotated into a plantar and medial direction. The talonavicular joint is dislocated with the navicular at the dorsum of the talar neck. The talus is actually vertically oriented. There is eversion of the calcaneum, tightness of the Achilles tendon, peroneus longus and posterior tibialis tendons sometimes then act as dorsiflexors. What we see them in this is an MRI where you can very clearly see that the talus is pointing downwards and the navicular is sitting dorsal to the talus. So that is differential diagnosis, and this was actually some of it was covered. The oblique talus, the flexible one we talked about, and there was some discussion with Q&A. And then the next one is the calcaneovalgus. So one has to differentiate between these. So this is a congenital classic stiff vertical talus. Compare this to this one, which is an oblique talus, a flat foot, nothing doing, just reassurance to the parents, observe, and they improve with time. Then the next differential diagnosis is with the calcaneovalgus foot, and that is associated with the posterior medial bowing. Again, most of the time, one has to be just careful, just to keep an eye on them. They grow up. Sometimes they do have some shortening and deformities which may need correction, especially the leg length deformity. So if you look at the X-ray, you can see that there is a talus that is pointing downwards, and the angle between the talus and the metatarsal is quite wide here. And we are going to talk about that in a minute. So there are different angles. If you see the black line, that is the talus, and the vertical line is the talus that is facing downwards, and then you can see the metatarsal straight angle, and then the yellow lines is the tibial calcaneal angle. And with these that you see that there is no the talocalcaneal angle, the talo first metatarsal angle is the one which is most of the time that we are looking at, and I'm going to talk about that in a minute. So the talar axis first metatarsal, or the Mary's angle, and then the second one was the calcaneal axis and first metatarsal, and you can see that those are quite deep angles there. Again, I'm not going to waste time on this one. So classification, again, various types. They have been classified grade 1 to 5, or idiopathic and associated or not associated with neurological deficit, and associated with chromosomal aberration and neural defects. So the algorithmic approach to the congenital vertical talus, and this is one of our patients. So one has to see whether the talonavicular joint is reducible or partially reducible after a few casts. If it is reducible, then obviously only minimal invasion reduction is required. Just releasing the medial subtalar joint, plantar flexion, and abduction. If this is less than 10 degrees, then some lengthening of the peroneus longus brevis or the lateral subtalar joint release is indicated. If the joint is not reducible and the deformity is severe, stiff, or recurrent, then a transverse dorsal incision for the dorsolateral releases is indicated. If the equinus is stiff, then a posterior release of the ankle and the subtalar joint. And if the medial column is too long, sometimes a naviculectomy has to be done. So when we look at the treatment, this is what the reverse Ponsati casting here we have been talking about, that midfoot has to be reduced through the midfoot with an adduction moment. So with the left thumb of the left hand on the head of the talus, on the sinus tarsi, and the right hand thumb on the navicular and the index finger just on the plantar side of the navicular. Apply distraction force and dorsiflexion of the midfoot, and that gradually, and supination of the forefoot, that gradually corrects it. So once you get some correction, you put on the cast. So this again is a reverse sort of a Ponseti cast, or the first cast of the Ponseti probably looks like this. Once you have these casts, a lot of these are quite flexible and they are reduced with this method. If this deformity is stiff, then sometimes you need to do a tendo Achilles lengthening as well as a posterior capsulotomy to get the calcaneus into neutral position. And sometimes one has to approach it on the lateral side and release the calcaneocuboid joint. This is a small incision on the medial side, and because unless you identify and release the tibialis posterior, you cannot actually bring the navicular back to this position. So once that is done, the navicular is brought into position, then a retrograde wire is put in, the joint is reduced, and then the wire is transfixed from the posterior to get this correction here. So that is the diagrammatic, and that's one of our patients here. So this is the patient post-operatively, the x-rays. You can see that the clubfoot has been corrected compared to the initial x-ray. So post-operatively, above knee cast with the knee in flexion, ankle in 15 degrees of dorsiflexion, forefoot has to be in plantar flexion and inversion, and the heel in 10 degrees of inversion. K-wire is generally removed at 3 weeks and the plaster is changed, walking cast applied for 6 weeks afterwards. Then this is the post-operative protocol, change to AFOs, remove the K-wires, and then the bracing protocol, full time for 2 months, then wear 3 hours every 2 months until night time only. Basically use the brace for at least 2 years if it's an isolated deformity. Follow up obviously until maturity. The clinical care point says that the early diagnosis allows the early and successful minimal invasive treatment. Open reduction of the talonavicular joint may be required if the closed reduction fails. Syndromic and neuromusculars are much more difficult to treat. Periarticular release only necessary in very severely deformed and rigid feet. Thank you very much, sir.
So next,
I can change it into a comment that there's a high risk of recurrence even after vertical damage surgery. Yes. So do always consider transfer rather than keep it than that. And sometimes we have to do a naviculectomy. I never had to get from doing that. The space is constrained. When I was talking about the algorithm, I talked about that naviculectomy, but as I said, but the problem that there is so I just skipped all of those details. Yes, but
thank you. Thank you, sir. I would like to invite Professor Mohammad Moram Anam for next talk. The topic is systemic approach to plate deformity in children, clinical evaluation, imaging, and evidence-based imaging.
Changed the name. I don't know. You changed the name. What is that? How did you change the name?
Babe?
This one is, what is that?
Yes.
No, this one is that. I told the guy.
This name?
If I can answer? You want to talk?
इसमें भी नहीं है.
क्या नाम है? Moramina. That's one.
More
But
amino.
it's not the correct
Okay. This one? This one is not
one.
correct?
Not.
Just one, yeah.
Free paper.
I don't understand. Why did you change the name?
I think this one.
Yeah. Thank you. Great.
This one.
So do you have a pointer or something?
Good afternoon, and chairs and audience. I think the difficult day and many information. I try to make a little bit short, I hope. This is the plan is just we know that that's the description of the how food developed. This is we know that first 5 years is very rapidly growth, and the first years at the girls it is coming to half of the adult size, and this is the up to 4 years old. This is physiologic, and we know that up to 8 to 10 years it will be resolved. This is the very common findings for that. And if you go to the past plans, there's a two description: physiological or pathological. Physiological means flexible, and pathologic means rigid. And why do family comes to clinic? Because that's the good thing is that almost 90% they are coming for the cosmetic reason. And pain and functional limitation and abnormal sugar is coming older than the 8. But at early age is they are coming for the cosmetic reason. This is the very nice the paper and showing that how can you differentiate the diagnosis. This is the congenital flat foot, contracted foot, physiological foot, and the neuromuscular foot. What is the etiology, what is the clinical findings, what is the inspection, and what is the treatment. This is a good summarize for that. What is the clinical findings? It is the collapse of the medial longitudinal arch, hallux valgus, too many tauci, and the forefoot abduction and external tibial torsion. There are many measurements. If you go to the textbook, you can find it too many. That's why it's just I go directly to, sometimes we need three-dimensional X-rays and the MRI, and we usually use the dynamic evaluation, like the pedobarograph, because it shows how the weight distributed on the clinical examination. We have to check on the medial side if there is any accessory navicular or dorsal bunion, and we have to check the peroneal spasticity or shortening, and we have to look at how kids walk, because the external rotation is important, the patellar position is very important. We can talk about the visual gait analysis, but we have to check all the rotational profile during the examination. Femoral anteversion, we know that this adaptation of the femoral anteversion is coming with the tibial external rotation and pes peroneal valgus. Without correcting the femoral anteversion, if you go directly to the foot, you will do big mistake because recurrence is 100%. And this is the examination is very important for the young junior orthopedic surgeons. This is the examination of the flexible flat foot. If they go tiptoe, the calcaneus should go varus. This is the flexible. And with the arches of the foot, we have to control with the first hallux extension. It shows how the flexible of our arches. That's important. Coleman block test to understand the static and dynamic deformity on the hind foot. And also, I use this test because sometimes the kids is not very easy to go for the Coleman block test. Supination or pronation of the forefoot should change the calcaneus position in the valgus or varus position. That means it's dynamic or static. That's the very good examination for these kids. Also, we have to check the Achilles tendon because we know that etiology of the pes perennial valgus is coming sometimes for the short Achilles tendon, and that's the everybody knows that's the congenital, the Achilles tendon contracture or the shortening. That's very important during the examination. What is the aim of the treatment? No symptom, no treatment. That's the basic things. And if symptomatic, we are starting with the exercises, show modifications, and sometimes, of course, we are going to surgeries. This is the studies showing that there is no influence with the show modification. If this graphic shows very well, no difference, show modification doesn't help for the medial arc restoration, and this is the good study showing that this is the saying that if you use the shoes, you have a higher risk for the pes pellanus in the younger age. That's why it's very important, no show modification for this patient's group. Then I am coming to our subject is surgical options. Soft tissue balance procedures, there's some fusion in the tarsal bone, extra-articular osteotomies and the combination with the soft tissue, arthroeresis and triple arthrodesis. This is the indication. Sometimes we combine them. The tibialis posterior is very important for the augmentation or advancement because that's a soft tissue procedures. Sometimes if there is an insufficiency of the tibialis posterior, you know, I think many people use it. Flexor hallucis longus augmentation is possible with these surgeries. Arthroeresis, personally, I don't like to use any implant in the joint in anywhere. That's why I don't use it. But calcaneal block is the calcaneal block screw is named also arthroeresis. From Italy and from the Korea, from Thailand, there are many good studies showing that very good results. I have a couple experience. I started doing that after the long follow-up. Results is okay, but one of 3 patients has a pain because of the head of the screw. That's in the auto extra-articular, just they are saying that this technique works because there is a proprioception effect with this screw. Up to you, that I don't want to use too much. Lateral column lengthening, I spoke about it the first day in the neuromuscular part. This is the open techniques. I don't use too much. That one is anymore. But just old one is I just use the bone graft, and this is the techniques I showed, and this is the case I want to show it because I changed this presentation a little bit after talking the first day discussion when we do what. Then this is the problem for the pes perennial valgus. We have a hindfoot valgus, forefoot abduction, forefoot pronation, and pes pellanus. Let's go to X-ray. There is the talonavicular coverage angle is less. We see this is in the lateral direction, we see the talonavicular angle. But this is the problems. The valgus in the hindfoot can be solved with the calcaneal osteotomy. Forefoot abduction can be solved with the lateral column lengthening. Forefoot pronation can be solved with the cotton osteotomy, cuneiform osteotomy. Let's go in the surgery. First, if you need, because the soft tissue balance is very important. If you have a tight peroneal tendon, you have to do elongation of the peroneal tendons and augmentation of the tibialis posterior. This is first we start with the Achilles tendon lengthening, lateral column. This is the lateral column lengthening. Please look at after the calcaneal lengthening, look at the calcaneal position. It is still in the valgus. If there is the valgus, we have to go the posterior hindfoot osteotomy. We have to correct the medialization of the hindfoot. This is the position now. And look at the forefoot. You see the supination. If you leave like this, you correct the hindfoot and midfoot, but not the forefoot. That's why we have to go cotton osteotomy, and we have to take the flexion of the first ray. Then you can have the good you can correct the forefoot abduction and the hindfoot problems. On the X-ray, this is the nice arches, and you see the talonavicular coverage angle here. How it differs. That's why step by step we have to go. And we can see the problems. This is I want to talk 5 minutes about this is the rigid pasperonovalgus, this is the tarsal coalition, this is the anteater sign for the calcaneonavicular fusion, and this is the incision. That surgery is easy. This is the calcaneonavicular, the excision of the coalition is not so difficult, and you have to control intraoperatively. You have to excise all the structure. You don't leave any part of them. And this is the talocalcaneal. Talocalcaneal is require some experience. You have to be careful. You have to watch from somebody's first. You are taking the tibialis posterior to the plantar, just distal to the medial malleolus. You will go and you will find this is the coalition, and this is the incision, a little bit big. And you see the difference here. We have to resect the whole that's the talocalcaneal fusion, then the resection. And intraoperatively, you have to control the hindfoot mobility. That's for sure. Thank you very much for your attention. Sorry for it is very late. I do very fast, but I have.
Thank you, sir, Professor Anand. So, any question we have time?
So, Dr. Thank you for the presentation. What do you think about correcting the vestibular valgus deformity and doing the bar resection together? Should we do them in separate sessions or should we do them
No, that's a good question. There's just the intraoperatively. I didn't want to go so detailed because of the indication of the resection of the talocalcaneal, this coalition. But when you correct it, the intraoperative, you have to resect first. Then you have to check the hindfoot. If there is a valgus, you have to correct it in the same operations, because otherwise it doesn't work very well. In the younger age, they are saying that there is this is the valgus position is getting better, but you have to check the mobility if there is any secondary problem. But intraoperatively, ask again, because there was a sound that I couldn't hear. Sorry. Yeah. No, I do same. If this is the symptomatic, I resect the bone. I just do advancement of the tibialis posterior. I just suture it a little bit distally. That's just tightening the tibialis posterior. I do same things, but we know that these things from like a dorsal bunion in the cerebral palsy, when you take there, because of the pulling these tibialis posterior from the apophysis of the navicula, when you resect the navicular part, also the cartilage part, it's very helpful. Then you can attach the tibialis posterior, suture that tibialis posterior to the navicula is the good one. Just only resection of the navicula is not quite enough. You should take some part of the navicula and suture it, the tibialis. Yeah, that's. Thank you. Thank you very much. Thank you. I would like to thank all organizing committee inviting us here. That's an excellent meeting. Thank you very much for everyone.
So, our next topic, I would like to Professor Kamran Sahab
Bismillah ar-Rahman ar-Rahim. Yeah. Rabbi Shrali Sadri Vasili Amri Wahlul Uqdatam Min Lisani Yafqahu Qawli. I thank the organizers, esteemed colleagues, for having me here. Assalamu alaikum. Going back to something specific to hand and a bit of a soft tissue thing. Syndactyly is quite common, as we all know. इसको इससे चलाना है यहाँ से इससे चलाना है okay. So there are some definitions. Obviously it's a Greek word. Syn means together, dactylos means a finger, so the fingers are together, as we know. So this is failure of separation of the digits during embryologic development, so we know that. So most common congenital anomaly in the hand is 1 in 2000 live births. 40% cases do have a family history. 50% is bilateral. Long and ring are more common. Boys more common than girls. Now we know it's abnormal slowing of growth and development during the 7th and 8th weeks of gestation. It's autosomal dominant tract in long ring fingers syndactyly. It's not always autosomal dominant tract, but in some cases, yes. Some reports say that there is association of maternal spoking. Now, these are certain terms that come on very frequently, like acrosyndactyly, which is lateral fusion of the adjacent digits distally, with proximal fenestrations between the joints. So this is called acrosyndactyly. Brachysyndactyly, when brachy means short, so we know shortening of syndactylized digits. So brachysyndactyly is one of the features like in Poland syndrome. Synonychia is fusion of the adjacent nails. Clinodactyly is curvature or bend of the little finger towards the adjacent finger. Symphalangism is congenital ankylosis of the proximal joints of the fingers or toes. And a delta phalanx is an abnormal extra trapezoidal phalanx, commonly in the phalanx 1 thumb and P2 of the little finger, causing angular deformity. Now, I'm not going to go into these details, but these are some certain terms that always come when you discuss these topics. So there are associated abnormalities like webbing of the toes, polydactyly, constriction rings, brachydactyly, cleft feet, hemangioma, absence of muscles. Like in Poland syndrome, spinal disorders, funnel chest, and heart disorders. Now, many of us might have seen Apert syndrome. You can see special features. This is acrocephalosyndactyly. It is 1 in 160,000 or 200,000 live births. So there are characteristic facial features and upper and lower limb abnormalities. There is radial deviation of a short thumb, as I said, a delta phalanx, complex syndactyly of the index, middle, and ring. In fact, the only simple syndactyly is between the ring and little finger in most of the cases. So what you tend to separate in the end is the first web, which is the most important, and sometimes the little finger, and most of the time the little finger of the mass, the central mass. The central mass does not require any release because most of the time they are good together and not good when you try to separate them. So this is type 1, which is a spade hand, as you can see here. Again a type 1. In type 2 you have a mitten or a spoon hand, but even here you can see the thumb is relatively separate, although it's not a normal web, but it is relatively separate. Whereas when you see this one, which is a rosebud or horse hoof hand, there is no thumb. Actually there is a thumb, which is right into this mass, and it is the most critical part of this particular deformity, that you take that thumb out. And taking that thumb out means first web reconstruction. So it may actually require a flap, actually always requires a flap. So this is a very complex soft tissue reconstruction, taking the first part of this. And again, even in this one, you can take the little finger out in many of these cases. So at the end, you have a central mass, which is competent together, and you have a thumb, which has a reasonable web, and then you have a little finger. So the hand becomes more functional, because like this, it is not functional at all. So another syndrome which I tend to see quite common. In fact, we used to think that it's written in the book. It is not so. Poland syndrome is quite common. There is absence of external head of the pec major, and along with that there is a deformity. There is hypoplasia of the digits, there is brachydactyly, there is syndactyly, there is sometimes aplasia and symphalangism. So you see a short digits, you see syndactylized digits, and this is not like Aperts where everything is mitten together. It's not like that. But you have to see the patient as a whole. Then you see many of those patients who present with hands like these, they might have loss or some problem with their pec majors. So it was first described by Alfred Poland. He was a good student. He found that during dissection when he was becoming a student. So we should always try to see patients thoroughly. Now this is an example of Poland syndrome, one of my patients you can see here. This is another example of Poland syndrome. You can see relatively shorter digits. So obviously they are partially syndactylized and they are short digits, but they are functional, so you can release that syndactyly, and it ends to very good function in long run. So this is a general classification. We can classify it many ways. I tend to be simple. So it can be a simple incomplete, it can be a simple complete, it can be complex. When I say complex, I mean the distal phalanges are fused together. There is synonychia or there is fusion of the distal phalanges. But then it's complicated, which may be syndromic, like Poland's, like the Eppert's or something else. Sometimes you have intervening digits in between the digits, and you don't know what it is until and unless you see very good x-rays. You won't be able to identify the problem and obviously correct the problem. So Flat said that congenital malformations are some of the most difficult problems confronting the hand surgeon. Perfectly right, because a single surgical procedure cannot be standardized. Like, it's not a cookbook technique that you can do this thing for all patients. So this is why you have to have armamentarium of procedures to deal with these. So what are the indications of release? A complete or partial simple syndactyly, it's an indication for release. A complete complex syndactyly, it's an indication of release. Syndactyly hampering finger motion, syndactyly causing rotational and angular deformities. Now, when do we have rotational or angular deformities? When we have unequal digits. So the border digits, the thumb and index finger are not equal. If they are fused, obviously there will be a rotational and angular deformity. If the ring and little finger, obviously there will be an angular deformity. Theoretically speaking, the middle and ring fingers are same size, but they are not. But I have seen people at their 80 years of age with complete simple syndactyly of ring and little finger without any problem. But obviously, if they had met me before, I would have released that, because cosmetically it would be more appealing. But anyway, so if the digits are equal, then the problem will be lesser. And if the syndactyly is simple, there is no bony fusion, the problem will be relatively simple. So, contraindications, complex syndactyly in whom the conjoined fingers together are functional but individually hypoplastic, or they cannot function individually. Like in Epert syndrome, the central mass, if we are too keen and too enthusiastic to bring fingers out of that, maybe we get nothing but two masses which are not cosmetically appealing, but they still don't function. So combined it might be functioning. So separation of the conjoined fingers may make two individual digits non-functional, because only one set of tendons and maybe one set of neurovascular bundle, you may end up in necrosis because there might be one set of neurovascular bundle. So be very careful. Usually it's done before school age, but with border digits, you should do early. So we should not do it before, try not to do it before 1.5 years of age if the problem is not complicated, if the problem is not syndromic, and if you are not dealing with border digits. But border digits should be done as early as possible. I tend to do them at before 6 months of age, because I don't want to have contractures and rotational deformities. But the rest, usually after 1.5 years. The only argument of not doing early is that you can have a web creep. There are other ways not to have a web creep, but still, if the digits are equal, if the thing is simpler, you can go slightly late. If they are complicated, if they are border digits, try to be early. Now, anatomy of the web has to be understood. Web is not a rectangle. Web is not a square. Web is not. So it's, if you see your web like this, if you go distally, it is wider. If you go proximally, it is narrower. So web has a structure. So you have to make that structure when you try to release the syndactyly. So these are the steps of reconstruction. You have to separate the digits. So commissure और वेब रिकंस्ट्रक्शन, अगेन इट्स दी मोस्ट इंपॉर्टेंट पार्ट. मैं अक्सर लोगों से सुनता हूँ कि वो आप डॉक्टर के पास जाएं, वो एक कट लगाएगा और कट लगाने से सही हो जाएगा. भाई कट तो नहीं लगाना, कट लगाने से तो कुछ भी नहीं होगा. जब तक आप वेब रिकंस्ट्रक्शन नहीं करते, कट लगाने से कुछ भी नहीं होगा. सो इट्स नॉट कट लगाना. And resurfacing of the adjacent surfaces of the digits. Now 50% of this surgery is good resurfacing. If you end up in the end with bad resurfacing, any bad grafting, then you are going to have problem for many months. So this should not be the end point of any surgery. There are many surgical techniques. This is one of the techniques which is described by Bauer et al. And you can see number A is the dorsal rectangular flap which will make the web. On the other side, if you see, there is a flap number B, which is the web, adjacent web flap. On one side, one of the web will not be resurfaced by an adjacent flap. And then there are zigzag flaps, which are sort of mirror image flaps. Now, when we say mirror image flaps, we have an impression that they rotate, they are mirror image, so they will resurface each other and there will be no defect. This is not the case, because it is always less skin. So the skin is always less. Don't try to mirror image them completely and close them, because in the end you will have more necrosis and more soft tissue problem. So you end up having a skin graft in almost 90% or more than 90% of the cases, and do that. So this is the sort of release that you tend to have, and then reconstruction. This is another technique in which you don't see the adjacent web flap. This is by Herndon. I don't like it, but anyway, many people do that. So I tend to use the Bauer et al. Technique. I have a modification. I use long zigzag flaps, and so not the short ones. But still, this is also accepted technique. Many people do that. This is another variation of the same thing. But you see, the most important part is a flap which is going to make the web. Now this is one of our case. You can see both hands, they have syndactylies. And this is after release. So these are the long-term results that you can expect. This is another patient, again, the same technique. And if you see the diagram here on the lower side, my zigzag flaps are very long, so I'm not using short flaps like the one you see in the text. And again, see the result in the end, good function, good cosmesis. This is case example 3 again. So one of the finger has already been released, middle ring and little fingers syndactyly bilaterally, and this is the result in the end, all fingers released. Obviously, this is a staged release. You cannot release 2 adjacent digits at the same time. You should not, because then you might end up with necrosis of one of the digits, because you don't know the actual vascularity. And it is not about angiography. It is about seeing what at the time of surgery. You might not even know, even if you do an angio, what you are seeing. So this is another technique by Skoog et al. You use volar and dorsal V-type flaps, and they both merge in the web, and then they make a web. There is a scar in the web, but obviously that diminishes with time. So this is another patient. This is a syndromic case, and you can see 3 fingers, already 1 finger less. So this is after release, and you can see in the diagram on the right lower side that both of the V's have gone together and they have formed a web. The web reconstruction is the most important part. Okay. So this is the late result. This is another technique by Niranjan and D. Carpenter. Because they thought that by doing this, they can obviate the need of a skin graft. It's a good technique. It's a modification of a flap. We have done it in few of our cases like this, but they have to be short, simple syndactyly segments with flexible skin. Otherwise, you cannot do that. Obviously, this is a case of Appert's acrosyndactyly. Again, there can be a dorsal metacarpal flap, which you can do that. I tend to keep that as a reserve in cases where there is a problem rather than doing it as a routine. So I don't do that as a routine, as you can see in some of the papers here. So I'm not doing that as a routine. So in short segments, you can use multiple Z-plasties. There is a technique called 4-flap plasty. There is a technique called 5-flap plasty. So there are multiple techniques that you can use for short segments. Again, for synonychia reconstruction, like these flaps can be done, so you can have a better adjacent nail or the synonych, when you release the synonych. I don't do this. Elizarov can be used for distraction in syndactyly, but the hand is about function. So I tend to like get away from this, because I can do that, but at the end I might have fingers which are not functioning very well, which may be stiff, the joints may be stiff. So I tend to do this less. But yes, in very complicated situations, sometimes you can consider that, but not as a routine. So these are the complications. God forbid one should not have this, but digital necrosis. And obviously, if you try to do all syndactylized digits together, you can have it. Okay. बंद कर दूं फौरन? Failure, skin graft problems can be there. So it can be because of poor immobilization, poor defattening. Now, don't defatten, please. Defatten only when it is absolutely needed. Don't try to defatten things, just try to close them. So there can be some hair growth because you tend to have the graft from the groin, so at times there is a hair growth on the hand. If you tend to take very small flaps, like when you're making a zigzag, you can have failures. There can be nail plate deformities, some flexion contractures. Especially when you have complicated border digits, there can be residual contractures, but you have to tell that patient before. So web creep is a problem. Sometimes you might have to redo surgery, but again, it depends on the loss of function. Don't try to do that all the time. There are techniques not to have. You can have the web a bit proximal when you do the first surgery, not to have a web creep, and you can change its design. I don't do cast immobilization at all, just good dressing. It is as good as a cast. But yes, you have to be very careful. Sometimes I have to go back. I tend to do it lesser now. Sometimes you have to go back, give a short GA and take all sutures out, take all the crust out, because otherwise the children don't let anything do. And they have a crust on for a number of weeks and months. So sometimes you have to do that. But obviously GA is a GA. So use caution when selecting digits for release. May keep the incision slightly more proximal than the palmo digital crease to not to have a web crease, zigzag closure of the commissure rather than transverse. And again, judicious defattening of the flap. Don't try to do it all the time. Take skin from the hairless part of the groin, and appropriate dressing and immobilization to have uniform result like this. Thank you.
Thank you. Thank you, sir. The session will be after the session because due to time.
सर शुक्रिया. मतलब कोई सवाल हो तो बाद में सर इंशाल्लाह.
Thank you, sir. So next up, I would like to invite Dr. Ramesh.
Assalamualaikum. Thank you, everyone. I kind of want to just give some more time to let Dr. Kamran talk some more about his experience. But my question shuru kar lo ek? It's your opinion on taking skin graft from the upper extremity rather than the groin. Do you think we should consider that from the wrist or the arm rather than from the groin?
I'm not saying that. I'm not saying you take it from the upper. You can take it from the groin. I always take it from the groin. But sometimes if you have multiple digits and you tend to have poor groin skin, because you can even take the graft again. Once I've done the grafting and it healed, even from that particular scar you can take the graft, and even that heals. So I take it recurrent from the groin. Sometimes I take from the upper limit needed. For instance, like the wrist crease, but it needs to be very small, or hypothenar eminence. Like hypothenar eminence has a whiter skin, so if you need a whiter skin, you can do that. So what I'm saying is, when you take from the groin, take from the hairless part of the groin, rather than from the hairy part of the groin. Otherwise, you might end up with some hair on the finger, which is cosmetically discreet. This is what it is. Yeah, move them as early as possible when the graft heals, because until and unless the graft heals, the mother and the father and the child is always at risk, and the child is always crying. So as early as there is healing of the graft, I would ask them to have warm soaps and movement, and they can apply some emollients like a polyflex, the eye ointment, the better one. So they should move as early as possible. So it takes 3-4 weeks before they start actual movement, but I don't immobilize, I don't put plaster at all. Sometimes in complicated digits, like water digits, you might have to do KY at times because the joints are unstable for
Okay, thank you. I know it's getting late. I'll skip maybe half of the talk just to keep on time. This is, the talk is really about the concept of trying to use AI modeling for decision making in pediatric distal radius fractures. Not everyone is always as knowledgeable as the people in the room about who needs to do what. So the project is comparing two types of AI models, but it's just an example that anyone can use here, inshallah. So, bismillah, we'll just begin, we'll write in. Everyone knows what AI is in general, but the idea is there's different types of AI models out there. They're all based on these large language modeling. We're going to skip through some of this. There's machine learning as well, which is a subset of AI where the computer is actually learning and changing over time. And then there's artificial intelligence, machine learning within that deep learning, and then all the way at the bottom is generative AI, which is what's being used more and more now. So just skipping some of the theory, this is the model that a few of us at Dartmouth have developed to try to use in distal radius fractures, but it can be used for anything. This is just what we started with. The idea, the important idea is this RAG model. You choose what the input is. Any AI model is only as good as what it's looking. So ChatGPT is great, but it searches the entire internet. The RAG model, you choose what data to put in. So we've chosen the Academy, JPO, JPOS, and we've chosen what goes in. So as they say, garbage in, garbage out. So we want to make sure only good data is going in, and then you can choose a model. So that's the big picture. We'll skip through all this to get everyone out, but I'll just tell you what the project actually is. This is just how the RAG model works. Anyone can ask me after. So the idea was, can a custom RAG model be designed to try to help distinguish between treatment options for pediatric distal radius fractures? Who needs a reduction? Who doesn't need a reduction? It's never going to be perfect, but if it can be good enough for our emergency room doctors, for our urgent cares, where there is no orthopedic surgeon. So 300 cases were designed, and you tell the model, pretend you're an expert pediatric orthopedic surgeon, here are the parameters, and you put the parameters in. You tell it the age, you tell it the angulation, you give it all the numbers that you would be able to measure. Inshallah, one day the AI could measure also. Right now we have people measuring, and you enter. So this study took 300 different vignettes, and we chose examples that everyone would agree on. We know there's many fractures we would disagree, but certain fractures we all agree on. A 5-year-old fracture with a 5-degree angulation, we all agree. A 12-year-old with a 30-degree angulation, we all agree. That's what we chose. So we put them into the model. We curated data from all over that we could find. And again, these are the numbers. The most important part is the conclusion. So we compared the RAG model to generic ChatGPT. Actually, ChatGPT was 77% accurate, 78% by what we would consider accurate. We can debate what's accurate. This model was 88%. So it's better overall, as you would expect, because again, we're choosing what data goes into it. Still not perfect, and the idea was this is a better model than what exists, and what I think is most useful. So it might improve the care if you can have a close to 90% accuracy just from this, and then treating physicians can implement in areas where there's no orthopedic surgeons. So what does this mean for in Pakistan? You can put in Pakistani data. You can have JPOSP. Inshallah, when it's published, you can have that as an input into the model that you can choose, because we all know treatment and decision making is location specific. Maybe you can even make it province specific. Maybe in some areas of Pakistan we should have different indications versus other areas. You can customize it however you'd like. And it can be set up in remote areas to decide who needs to take a 6-hour bus ride or something to another hospital and who can just take plaster at home. There is no way that people in this room can review every x-ray in Pakistan. It's not possible. No matter how many fellowship trained people we get, there has to be someone to do that initial just triaging. So if you can have an 88% accurate triaging, this is a possibility. So in the future, there's all sorts of ways you can use the model to actually develop it further, use it in different fractures. And then lastly, this is my last slide, I want to thank everyone also for inviting me, the organizers. During this conference, a lot of discussion has come up about pediatric upper limb. It's been very exciting. Anyone who's interested, we've created now this week here with the people here, just a WhatsApp discussion group. If anyone would like to continue case discussion, I would love it if Dr. Kamran and others could join and provide just ongoing collaboration, research, and just to keep the discussion going. वो होता है ना conference के बाद फिर सब चीज़ चली जाती है. So we want a model that everyone can continue to stay involved. Any pediatric upper limb discussion, let me know. I'll learn from you. If I don't know the answers, I'll find friends who know the answers, inshallah. Thank you very much. And that's my email. Feel free to reach out.
We will continue to have fortnight discussion cases with you.
Absolutely. I am happy to join. I would love to hear your cases.
Thank you, Dr. Nisar.
I stayed under time.
Next up, that I would like to invite Dr. Noman.
Hello, Assalamu alaikum. Today, I have a topic to discuss is a growth disturbance after a pediatric fracture, its prevention and the management. The growth disturbance after the pediatric fracture most commonly occur after the fascial injury, and it may lead to the either angular deformity or the limb-length discrepancy. And the fascial injury accounts for the 15 to 30% of all the pediatric fractures, and the gross arrest occur in the 5 to 10% of the fascial injury. The fascial anatomy is important because zone is divided into the resting prophytic hypertrophic zone, and the hypertrophic zone is the most vulnerable where the fascial injury occur. But injury to the hypertrophic zone will not lead to the growth disturbance. Injury to the reverse and the prophytic zone lead to the growth disturbance. And there is a Salter-Harris classification, everybody knows, they divided into 5 types. Type 1, type 2 has a less risk of the growth disturbance, and the type 3, 4, and the 5 has a higher risk of the growth disturbance. Etiology of the growth disturbance is that either there is a direct fascial injury, according to Salter-Harris, higher the grade, higher the risk of the growth disturbance. If there is iatrogenic, if there is a repeated attempts at a reduction initially, and if there is an improper pin placement across the fasces, if there is a greater initial displacement, if there is a poor final reduction, inappropriate reduction. Types of the growth disturbance are the two. Either there is a complete arrest, that is will lead to a shortening, and shortening lead to a limb-length discrepancy. And the partial arrest will lead to the angular deformity. The common site of the growth disturbance are the distal femur, proximal tibia, distal tibia, and the distal radius. Pathophysiology is that when there is a fascial injury occur, it will lead to a hemorrhage. If it is not anatomically reduced, it will lead to a formation of the bony bridge, that is the fascial bar. And that portion will lead to the arrest, and the remaining fasces continue to grow and lead to the asymmetrical growth and the angular deformity. If there are two types of fascial bars, either central or the peripheral. Central fascial bar will lead to the arrest in the longitudinal growth, lead to the limb-length discrepancy, and the peripheral fascial bar will lead to the limb-length discrepancy, also the angular deformity. The patient present with usually with the limb-length discrepancy, angular deformity, and the gait abnormalities after the growth disturbance. And you have to diagnose on the imaging. Imaging is usually done X-ray to initial fracture assessment for the serial X-rays follow-up, and in the lower limb you have to do the scanogram to quantify the limb-length discrepancy, to see the level of the deformity, to see the extent of the deformity. And with the imaging, you sometimes need the CT scan for the bar detection, and the MRI also can be done for the early detection of the bar and to avoid the radiation. And what are the prevention measures? How you can prevent the growth disturbance? First of all, during the initial management, there should be a gentle handling of the fasces and avoid the forceful reduction, avoid the repeated manipulation, and you have to achieve the anatomical reduction, especially in the type 3 and the type 4 when there is an intra-articular fascial injury. And surgical principles are that whenever there is indicated, early fixation should be done, like in the type 2 and the type 3 should be fixed. And the pins, and according to pins and the wire placement, avoid the crossing the fasces, the pin at the periphery. Use the smooth wire instead of the threaded wires. And no more than 2 attempts should be made to insert a wire across the fasces. And whenever you place the implant must be positioned parallel to the fasces. Either you are placing the screw individually or either through the plate. The screw should be placed parallel to the fasces. If need, better to place the implant perpendicular to the fasces rather than the oblique, like when you are placing the screw in the neck of femur fracture after the pediatric neck of femur fracture. And the compression of the transfascial implant must be avoided. Follow-up, regular monitoring is necessary for at least 2 years to detect the growth disturbance early. Treatment options include the observation, bar resection, epiphysiodesis, osteotomy, landing. And in all the cases, the goal of the treatment is to restore the limb length, mechanical alignment, mobilize the adjacent joint, and correct the deformity without the cosmetic and the functional deficiency. Observation, in which you can observe if there is a mild deformity, like if there is a LLD is less than 2 cm, the patient is near to the skeletal mature. And there's some fracture like the cousin fracture. Cousin fracture is the proximal tibia metaphyseal fracture, which are prone to develop the valgus deformity. But with the time, they usually remodel and the deformity usually resolve. And the bar resection is indicated when the bar is involved with the less than 50% of the fasces, and at least 2 years of the growth is remaining. And after the resection, you have to interposition the graft. Most commonly, we use the fat, but you can use the silicone and the artificial dura as well. After the bar resection, the outcome is good if it is done early, appropriately on the time. And the epiphyseal disease, it is either temporary or the permanent. The indication is that if there is a physeal bar involved more than 50% of the physis, when there is a projected LLD is 2 to 5 centimeter. Temporary epiphyseal can be done by means of the guided growth to correct the angular deformity, and the permanent is done usually when the patient is near to the skeletal maturity to correct the LLD. This is a guided growth which was discussed yesterday by the Dr. Saeed Jodan. The permanent epiphyseal disease is usually performed to correct the LLD when there is an LLD of 2 to 5 centimeter. There are different techniques to correct the permanent epiphyseal disease. There is an older one technique is a Femister technique, this one, in which there is a rectangular bar is removed from the metaphysis, 2/3 from the metaphysis, 1/3 from the epiphysis and across the physis. And the physis is curated and that block is placed in the reverse direction up to 180-degree reverse. This will lead to the permanent epiphyseal disease. Second is the epiphyseal screws and the staples. And third one, which are most commonly nowadays used, the percutaneous technique, through which through the drill percutaneously under the fluoroscope, you drill across the physis and curettage is done across the physis and create the bar formation, physeal bar in the center. Like in this technique, you will place first the wire under the fluoroscope across the physis, and then you will place a large diameter like the pediatric DHS reamer, and then the curettage is done and will create the permanent epiphyseal disease. The main aim is to create the central physeal bar to correct the limb length discrepancy, and usually it is performed in the contralateral limb to correct the LLD. The corrective osteotomy is usually performed for the established deformity when the patient is skeletally mature. Either you can do with the plate or the Ellis rod. And the limb lengthening, last one. It is performed when there is a limb length discrepancy is more than 5 centimeter. Technique is either you can done with the external fixator by means of the Ellis rod or even uniplanar frame. It depends on the surgeon expertise on the facility. It also can be done by the intramedullary nail. This one is a fixator, Ellis rod, and uniplanar fixator can be done, can be used for the limb lengthening, and there is a telescoping intramedullary nail, that is a precise nail which causes a lengthening, but it is not available in the Pakistan. I have seen these 2 cases in the Hong Kong when I was in the fellowship. For the growth prediction, you have to maintain the green adhesion chart and the Mosley graph. It helps in the timing for the epiphyseal disease. The complication after the management can be occur. It can cause a recurrent deformity may occur, incomplete correction or the overcorrection can occur, infection in the joint stiffness also can occur. The summary is that early diagnosis and the proper management prevent the major growth disturbance and the deformities. Early recognition will require the less invasive correction, and the late cases will require the complex reconstructive procedure like the osteotomies. And the long-term follow-up is usually mandatory to see the growth disturbance after the pediatric fractures. Thank you.
Thank you, Dr. Mohan. Move on to our pre-papers. So I would like to invite you, Dr. Shah Faisal, the talk is on flow reduction and percutaneous drainage of supracondylar fracture.
Bismillahirrahmanirrahim. My topic will be closed reduction and percutaneous spinning of displaced Gatling type 2 supracondylar fracture of a humerus in children with delayed 24 to 72 hours. Presentation results.
Close reduction percutaneous spinning of displaced cartilage type 2 and 3 supracondylar fracture humerus in children with delayed 24 hours to 72 hours. Author is Dr. Hamallah Saab, Dr. Wazir Ahmed, Dr. Said Shah Faisal, Dr. Abdul Rahman, and Dr. Adnan Kamal. I have no conflict of interest. Approval study was approved from ethical committee of hospital. The aim of the study was to know the outcome of closed reduction and percutaneous spinning of displaced supracondylar fracture in the humerus in children with delayed presentation. The study was conducted in the Department of Orthopedic Unit 2 of Bollan Medical Complex Hospital, Quetta. The study was conducted from August 22 to August 2025, duration 3 years. It was a prospective and case series. Children of both sexes aged between 2 to 12 years having closed, isolated, and displaced supracondylar fracture of the humerus presented to the OPD or ER or ward within 24 to 72 hours after injury were included in the study. Both male and female children having displaced Gartland type 2 and 3 supracondylar fracture of distal humerus aged 2 to 12, duration of the injury 24 to 72 hours. Most of fracture were extension type. Children with less than 2 years or more than 12 years were excluded. Those presented with fracture after 72 hours were not included. Open fracture were excluded. Children with the fracture of other bones were not included. Non-displaced fracture Gartland type 1 were not included. Children having medical diseases like polio, CP, or blood diseases were excluded from the study. All the patients were admitted either through OPD or emergencies were arranged. Preoperative planning of fracture reduction and fixation was made before surgery and illustrated. Anesthesia, endotracheal general anesthesia, supine position, C-arm used, pressure, arm prepped and draped in standard way. Fracture was reduced in standard way by traction and counter traction and side-to-side manipulation. Reduction was confirmed under C-arm in AP and lateral view before fixation. Small incision of 1 centimeter over medial or lateral epicondi in case closed reduction was not possible, or pass K-wire from inner side to save the ulnar nerve. 2 pin from lateral side, cross pin 1 medial and 1 lateral, 2 lateral pin 1 medial. Majority of fracture were fixed with 2 lateral divergent pins. As you can see in the X-ray, this is the cross K-wires. And this is 2 divergent and 1 lateral pin. Initially, we take long time to reduce fixed gradually. It was reduced as a learning curve, average time 25 minutes. Anesthesia was safe in all cases. After surgery, plaster of Paris bake splint was given from upper arm to flexion crease of hand with elbow flexed at around 70 to 90 degrees over papias cotton. Analgesia, ibuprofen and paracetamol, child admitted for 24 hours. Limb was elevated on pillow for 24 hours. Distal neurovascular status and compartment syndrome was observed for 24 hours. Post-operative swelling not recorded. Post-operative numbness of little finger noted in one case, resolved after removal of K-wire at 3 weeks. No compartment syndrome or neurovascular problems. Direction was confirmed on both views. All the patients were discharged after 24 hours. Instructions were given in verbal and written forms about signs and symptoms of neurovascular and compartment syndromes. Follow-ups were at 1 week clinical examination done in OPD, at 3 weeks clinical and X-ray done to assess the bone healing. At 5 to 6 weeks, K-wire is removed and gentle rhomb started. At 3 months, clinical and radiological assessment done. At 6 weeks, final follow-up. All the patients were followed for 6 months. K-wire removed in the OPD at 5 to 6 weeks. In majority of the cases, K-wire was removed at 6 weeks. The results were assessed by Flynn criteria at 3 months and 6 months. Excellent results were at 3 months 20 and follow-up after 6 months were 24. Good were 6 and at 3 months 6 and 6 months were 2. Fair result after 3 months were 2 and after 6 months were 3. Poor results were 1 after 6 months. Pin tract infection was seen in 6 cases. It resolved after dressing oral antibiotic after removal of K-wire in all cases. Mild ulnar nerve neuropraxia was noted. In 1 case, it resolved at 3 months. Post-operative limited extension was seen in 2 cases after 3 months. It was concluded that the close reduction percutaneous spinning of the displaced cartilage type 2 and 3 supracondylar fracture of the humerus in children was safe and effective method in early within 6 hours and delayed 24 to 72 hours presentations. Limited number of cases, 30 cases in total, shorter follow-up periods up to 6 months. Author recommends more studies in future. Thank you.
Thank you, Dr. Sasha. Any question? So I would like to invite Administrator Dr. Ansar. The talk is a complication of food abduction rate, AFO, after the correction given for the constitution.
मुझे बता दे कहाँ किस तरह इसको सेट इसको करो या ना
Time point as delayed, and why did you exclude people who came after 72 hours?
Usually, sir, we had there are 40 days assigned to every ward, sir. We have different days that are that's why that's how we decided. We don't have consecutive days or alternate days. There are too much gap in our routines, sir.
The question was, how do you decide this is delayed and this is early? So, I heard you. Fracture up to 2 weeks thickness is usually considered early fracture because there is no callus formation. They can be manipulated easily. Once you see the callus formation, the deflection occurs after 2 weeks. Therefore, delayed case do not come in description within 24 or 48 hours. Am I right, sir? Yes. This was the question. Do you want to explain? Yes,
Thank you.
I'm not part of this study process. I would like to say that in our setup, the patient initially goes to the own center support. They are simply like that. So after the 24 hours, when the patient came there with this sort of compartment syndrome, so they included this criteria that the patient that comes in 24 hours, that was considered early. And those that patient come after 24 hours, they were late.
Assalamu alaikum. I'm Dr. Asnaf, fellow pediatric orthopedic unit, Hyber Teaching Hospital, Peshawar. Today I'm presenting this paper, complication arising from the use of foot abduction orthosis and Pound City treated club foot patient. The objective of our study was to assess the prevalence, progression and resolution of brace related complication and Pound City treated club foot patient with the aim of improving brace design, compliance and reducing recurrence. We did prospective study. This study was conducted from December 2024 to June 2025 at Hyber Teaching Hospital, Peshawar. Brace usability was assessed at 1 month using USAID adapted scoring tool with a mark 0 to 100. Data were analyzed using SPSS. Total 91 patients less than 2 years of age with corrected club foot Pirani score 0 were included. Those with prior surgery or incomplete follow-up were excluded. All patients underwent the Pound City method followed by foot abduction orthosis. Braces were fitted by trained staff and caregiver were educated on application. Patients were followed at 24 hours, 1 week, 2 weeks, and 1 month. Complications were recorded using a standard questionnaire. Treatment and compliance, mean casting duration was 6 to 8 weeks. Brace compliance was 100% with no relapse at 6 months. Early complication noted at 24 hours was pain 88%, skin redness 75.8%, blister 42.9%, and tibial swelling 26.4%. This complication was with progression of time mostly declined by the day 30. Redness 75.8 to 7.7%. Blister from 42.9 to 5.5%. Muscle weakness increases. Peak day 14. Late complication was brace breakage, 9 cases, sweating discomfort 24.2%. Mean usability score was 84.94 plus minus 13.89. Heel placement, most difficult step, discomfort reduced from 53 to 15 patient at 1 month follow-up. This is the figure showing major complication. At first 24 hours, the peak complication was pain and swelling and redness. With the passage of time, it decreases. A questionnaire was given to the patient, which include 4 questions. First question was putting shoes on, and second was how to lace the shoes, and third was how to place the heel at the bottom, and then fourth was to how to clip the shoes on. The most difficult task for the caregiver was how to place the heel at the bottom. My conclusion is brace-related complications are common but mostly transit, though some muscle atrophy persists or appear later. Improved brace design, caregiver education, and personalized follow-up are essential to enhance compliance and prevent recurrence, especially in low-resource setting. This is a reference. This article was published in Journal of Pediatric Orthopedic last year. Thank you.
Thank you very much. Thank you very much, Anis, for including our paper. Although it's the last paper, so I will try to do justice to this. Right. So this is a high volume experience of management of patients, pediatric patients, which we have done in the last 9 months. So, as you know, when we start our camps, these camps are done all over Pakistan, from Karachi till Kashmir. And whenever we do it, the patients, they are just coming out of, out of holes, and they are swarming. Every OPD which we conduct, there are around hundreds of patients, and at least we see something like 500 to 600 patients in our OPD before we start operating over them. Now, I will just go straight to our protocols, where first we see the patient, assess them, do investigations, and we see whichever patients are suitable for operations, we take them on, and in a day we do something like around 20 to 30 patients. Most of them are club feet patients. Right, can we do can we go for the right. Can we go right away, right onto the slides, into the videos? Can we show the videos? Let me, ye dikhaya. So the sort of patients, these are the sort of patients which we see. These are not the patients which are coming at initial stages. They are type 4 club feet patients which are completely deformed, facing your face. All sort of patients are seen. You can see this one, completely deformed. Now what I am coming at, that we do simple procedures and we do very, very few osteotomies for these patients and we get the results. Right, next one. So you can, this one. So you can see so we have presented all sort of deformities, and these are late presentation of clubfoot. Okay. So what I'm trying to come at, minimal interventions. First, it is the tendoachilles lengthening, and then maybe osteotomy of taking the cuboid out and arthrodesis. Next. So you can see this is all right from Azad Kashmir, Tanumad Khan, Faisalabad, Multan, and Karachi. So you can see the number of patients which we have operated. Something is like 1,000 patients every year. Next. And now, ek piche. Yeah. So the functional success is around 93.2%. And around 6% is no mortality, 6% is complications of the wounds, and which are very bad complications, which I'm going to show you. And this one, which we did last time in Tanumad Khan, we did 300 surgeries, and there were 12 complications, wound complications, which were very bad. And I will come to that, how to avoid them and what should we be doing. Now, you can see this particular patient. This is the PMR release, in which we are doing revision surgery. There is no need for, as far as I am concerned, there is no need for PMR in today's world. You can do simple, start with, in the early phases, you can do Ponseti, and later on you can do TA lengthening and at the most pelocalcaneal opening up and tibulus posterior lengthening. That's it. You don't need more than that. And the ones which you are seeing, the PMR ones, we see loads and loads of them coming up for revisions. Next one. Now, stop there. Now, what I'm trying to come at, that I was telling Kamran Sahib as well, that the reason for our success is our orthotic center, which is established in Chinyot. And whenever we do our surgeries, serial plasters at 2 weeks, and then after 6 weeks, when the plaster is removed, then we do bespoke orthotic supports for every patient. For every individual patient, they get bespoke orthotic supports, and then 6 weeks they are admitted. They are not released. They are admitted for 6 weeks for continuous physiotherapy. And 3 sessions are done every day for rehabilitation, and then after 3 months they get the results. Next one. So this was the orthotic supports. So as I was saying, only 12. These are our complications. You can see they're very bad. The reason for that, you can see there was one, the fifth finger, little finger was almost necrosed. So the reason is that when we send them home, they are lost to sometime follow-up, they don't come back. And when they go home, they are not taking care of their foot. Sometimes, they wet it, they start walking right away on that, and that's what we get. So there were 12 cases in our recent camp which we did in Tanamathan in January. And then we take them on, we treat them, do debridement,